The meeting will come to order. Today we're having a joint hearing of the Health Subcommittee and the Oversight and Investigations Subcommittee, and the hearing is titled H1N1 Preparedness, an Update of Vaccine Production and Distribution. We're going to begin with opening statements from the members of the subcommittees. The chairman and ranking members of the two subcommittees will be recognized first for a 5-minute opening statement, followed by 5-minute statements by the chairman and ranking member of the full committee and the chairman emeritus. Other members of the subcommittees will then be recognized for 2-minute opening statements. And I'm going to begin by recognizing myself. And let me explain that the purpose of this hearing is to get an update from the main stakeholders involved in the manufacturing and distribution of the H1N1 vaccine, and to shed some light on where we currently are in the process and what we can expect moving forward. The most recent estimates from the Centers for Disease Control are truly alarming. Over the past 6 months, it is likely that 22 million people in our country have been infected with the disease, and about 98,000 have been hospitalized. To date, it is estimated that 3,900 individuals have lost their lives to H1N1. Unlike regular flu that affects predominantly the elderly population, the vast majority of H1N1 deaths have occurred in people between the ages of 18 to 64. Even more tragically, the CDC estimates that 540 of these deaths have occurred in children. And these numbers are significantly higher than earlier estimates, and as we move further into flu season, we can only expect to see them increase even more. We now know that this virus and vaccine is unlike flu vaccines that we've produced before in that it is extremely difficult to grow. Early estimates on vaccine amounts were based on how vaccines usually behave in the production phases. Unbeknownst to anyone involved in this process, H1N1 proved to be very different. And though the manufacturers have been able to speed the growth of the vaccine by selecting the fastest growing strains, we still are lagging behind where we originally thought we would be with our production numbers. Fortunately, though, this particular vaccine appears to be highly effective in creating an immune response in individuals, and for adults, one small dose of the vaccine will produce enough of a response to protect from H1N1. But these early delays in production are now rearing their ugly head as our country watches the disease spread and takes lives while vaccine is still hard to come by. To date, nearly 42 million doses are available for distribution, which is about half of what we originally expected to have by this time. It's no wonder, therefore, that story after story in the papers and on the news highlight the frustration that the American people are facing in trying to get the vaccine that would protect them from the disease. We hear accounts of individuals waiting on lines for hours at clinics. Some cannot find clinics in their neighborhood at all, and areas are still waiting to receive even their first doses of the vaccine. There's a school district in my hometown, for example, that is yet to receive the vaccine, and understandably the parents are irritated. And this frustration is exacerbated by accounts in the country that seem to have more than enough vaccine, in some areas, while getting this vital production from H1N1 poses no difficulty at all. So we're getting a lot of disparities from one place to the next, and naturally people are confused and they're angry. So that's why myself and Chairman Stupak are holding this hearing today. I personally would like to better understand how the production of vaccine is going, when, for example, we'll be able to expect enough vaccine so that all individuals who want it can get it, and will this happen before flu season is over? I'd also like to understand more about the distribution process. I understand that the states make their own distribution plans and do the ordering for their state through the CDC, but how are these plans created, and how do states make the determination where to start with vaccine distribution and which distributors to prioritize? We have a number of very important individuals with us today who've been working around the clock on these issues, and I'd like to welcome you all. We appreciate your taking the time to provide us with this update today. We understand how difficult this process has been. We're not here to beat you up, but we're here to try to get some answers, and particularly where we go from here. So with that, I'd like to let me just thank again Bart Stupak, Chairman Stupak, for working with me to put this hearing together. And I guess we're going to go to Mr. Walden at this point for an opening statement.
Well, thank you very much, Mr. Chairman, and thank you for convening this important hearing. H1N1 has been dominating the news and parents and general public's concern for the last couple of months, as we all know. I'm hopeful this joint subcommittee hearing can help answer questions and discuss solutions to the challenges arising from the first flu pandemic in 40 years. As many of you know, I have firsthand experience with H1N1. I think I was probably the first member of Congress to go on record as likely having being diagnosed as likely having H1N1. I'd not been vaccinated because, like the majority of my fellow members of Congress, I don't fall into the CDC's priority groups. And like millions of other people across the country who have had H1N1, I felt rotten for a few days. It's not something you want, and it's not something you want to pass on to others. But I did follow my doctor's advice and the CDC's directions and stayed at home here in D.C. to rest for at least 2 days after my fever broke, which is what I was told to do. And luckily, I was fortunate and recovered quickly. Others have not been so fortunate. Last week, we learned that approximately 4,000 people, 540 of them children, have died from H1N1. The fact that this flu hit young children so hard and the constant news reports about rising pediatric deaths have scared the daylights out of parents. You see this fear played out in the number of parents lining up with their small children at public vaccination clinics for hours at a time and flooding their pediatricians' offices with phone calls trying to hunt down the vaccine. From the folks I hear from in my district, they can't find the vaccines. Based on statements made by HHS and CDC, parents had counted on being able to vaccinate their children by October or November. Originally, CDC projected 40 million doses would be ready by the end of October. Ultimately, only 23 million doses were available. Instead, parents hear reports every day on the news about rising pediatric deaths and vaccine shortages and delays. Some wait in line for hours only to be told when they get there there's no vaccine left. Today, I hope we can get some concrete answers about when the vaccine will be available. I also want to hear from HHS and the vaccine manufacturers about the reasons for the delay and what can be done now and in the future. HHS Secretary Sebelius was before the full Energy and Commerce Committee on September 15th, and at that time she testified that by mid-October a, quote, large-scale campaign, close quote, for vaccinations would be underway. She also stated repeatedly that there would be, and I quote, enough vaccine for everyone, close quote. Secretary Sebelius now says the vaccine manufacturers painted an overly rosy picture of their production. Is that the case? Or did the virus seed not perform as expected? I don't think finger-pointing exercises are particularly helpful at a time when we're facing one of the biggest public health issues in recent years and a somewhat panicked public. But there have been repercussions. No doubt about it. I also want to learn about how HHS has assisted states and local health departments in preparing for this pandemic. For example, in my district, hospitals are implementing their incident command plans due to emergency rooms being hit with waves of patients with flu-like symptoms. These spikes of patients are coming at a time when doctors, nurses, and hospital staff are either homesick with the flu or taking care of their children that are home from school because of the flu. So we're looking at a situation of increased patient volume and decreased staff capacity. Hospital administrators are monitoring staff levels and patient volumes in some cases on an hourly basis, so if they reach a tipping point, the hospitals can cancel elective surgeries to ensure there's adequate staffing to care for patients in the emergency room and those admitted to the hospital. When I called the 18 hospitals in my district, each one of them asked, where's the vaccine that we were told was coming? So let's get the facts on the table about the reasons for the delay and when HHS knew about it. If there were production issues, how can they be corrected? And if there are communication issues between the manufacturers and HHS and the public, how they can be fixed so parents are not unnecessarily confused. When the administration promised enough vaccine for everyone, the people want to know that it's coming. I'm very interested to hear from Dr. Lori and both Drs. Lori and Dr. Schuchut about what direction HHS and CDC have given hospitals and how to prevent this confusion in the future. So I hope this isn't the last hearing we have on this issue. This is the first pandemic in 40 years and the first since Congress began providing funding starting in 2006 for pandemic preparedness. And at that time, we were deeply concerned about the possibility of a pandemic spreading a bird flu that could be 40% in mortality. Fortunately, this one has not proven to be as deadly. I believe Congress has appropriated $13 billion for this effort. This is an area where we need continued oversight so we can figure out what worked, what didn't, and what we should do going forward. So I'm particularly interested in the technologies for vaccine production and whether we can do better in the future. I understand that one of the manufacturers, MedImmune, has been able to meet its delivery schedule in part due to the different kind of technology that company uses to make a live attenuated vaccine. Even though MedImmune grows the virus in chicken eggs, which is uncertain and unpredictable in yielding a sufficient supply, they have achieved better results. I know that as part of its pandemic preparedness planning, HHS has awarded contracts to companies to look into cell-based vaccine production, as well as other ways to improve yields and production times. So I'd like to know about the status of these efforts and whether we're doing enough to ensure that we're prepared for a pandemic influenza. I welcome the witnesses and look forward to discussing these important public health issues with them. Thank you for your testimony. Thanks for the hearing, Mr. Chairman.
Thank you, Mr. Walden. Chairman Stupak.
Well, thank you, Mr. Chairman, and thanks for working with me and our O&I staff for putting together this hearing. Look forward to doing this joint hearing today, and I think we have a good hearing lined up. And as you said, we're not here to point fingers, but try to find out how we can do things better in the future. Today we continue our committee's oversight of the 2009 pandemic H1N1 flu by examining more closely the production and distribution of H1N1 vaccine. This will be the third hearing of the Energy and Commerce Committee as held this year on the H1N1 influenza. According to the Center for Disease Control and Prevention, as of November 13, 2009, influenza activity was widespread in 46 states, almost all which is likely H1N1 influenza. There have been 22 million infections, 9,800 hospitalizations, 3,900 deaths from the H1N1 virus, 540 of which have been confirmed pediatric deaths. This is a conservative figure because not every child who dies from flu-related causes has been diagnosed with the flu. To date, there have been more pediatric deaths from the H1N1 than usually occurs in the entire annual flu season. In September, Secretary Sebelius testified before the Energy and Commerce Committee, indicating that by mid-October, the U.S. Department of Health and Human Services would be up and running with vaccines. In fact, CDC had projected that 40 million doses of H1N1 vaccine would be on hand by October 15th, but not even 13 million doses had arrived by October 22nd. News reports have indicated that because of shortages in vaccines, doctors were dealing with worried and panicked parents who wish to have their children vaccinated, while state and local health care departments are experiencing long lines that can produce up to 5-hour waits for parents, children, pregnant women, and seniors. There have also been news reports indicating that private businesses, just as J.P. Morgan and Goldman Sachs, have been receiving the vaccines before individuals in the high-risk category. And let's not forget about the reports citing military officials saying terrorist suspects being held at Guantanamo Bay would receive the vaccine before most Americans. Like many districts around the country, my own district in northern Michigan has been affected by the H1N1 in a variety of ways. Since the outbreak began, Michigan has had over 500 schools shut down because 25% or more of their student bodies were absent with flu-like symptoms. Since September 1st, 1,226 people have been hospitalized in Michigan with flu-like symptoms, a 35% increase over last week when 801 cases were reported. The Oversight Investigation Subcommittee, along with the Health Subcommittee, have a responsibility not to merely rely on media accounts, but to get to the bottom of the situation. While we are not here to point fingers at who's to blame for the delay in the production and distribution of vaccinations, we do need to shed some light on the process between the government and the manufacturers. Given the urgency of the circumstances and the need for expeditious action, cooperation between drug manufacturers and federal agencies is imperative to ensure that our country is prepared to respond to H1N1 and future pandemics. When the H1N1 virus initially broke out, we knew very little, including how Americans would react to the vaccine and if we would need more than one dose per individual. A vaccine didn't even exist. We did not know how different H1N1 vaccines were from the vaccinations for the seasonal flu. In addition to discussing the specifics of H1N1 vaccine production and distribution, I hope we can shed some light today on our outdated vaccine process. It's my understanding that the manufacturing process for the H1N1 vaccine relies on obsolete egg-based influenza vaccine technologies that are subject to certain inherent uncertainties and delays such as incubation periods. As a result, we will continue to face similar challenges in responding to future influenza outbreaks, both outbreaks of novel strains such as the 2009 H1N1 strain and the pandemic or seasonal influenza we face every year. Many experts, including the CDC Director Tom Frieden, have said that it's important to develop new technologies such as cell-based vaccine production. We will hear from 4 of the 5 manufacturers that the U.S. government has contracted with to produce and distribute H1N1 vaccines. These manufacturers will give us an in-depth knowledge of the production challenges that they face and share their thoughts on how we can improve this process as we move forward. GlaxoSmithKline was not invited to testify at the hearing, as their vaccination was just recently approved by the FDA. Joining the manufacturers is Dr. David Lakey, Commissioner of the Texas Department of State Health Services, who will be the voice of the state health departments across the country, and Dr. Jeffrey Levy, the Executive Director of Trust for America's Health, a nonpartisan organization dedicated to making disease prevention a national priority. I look forward to hearing from all of our witnesses today and delving deeper into the challenges that both the government and industry are facing with the H1N1 pandemic. Thank you, Mr. Chairman. I yield back.
Thank you, Chairman Stupak. Gentleman from Kentucky, Mr. Whitfield.
Thank you very much, Mr. Chairman. And I suspect that every member of this panel has received many phone calls from their district, as I have, complaining about the shortage and wanting some answers and expressing their fear for their children and their family members. As you said, we've had about 3 hearings on this subject matter, but today I really want to focus from my perspective on really the relationship and the interaction between the federal government, the state government, and the manufacturers and the distribution process. Number 2, why have there been production delays? Specifically, why? And why has there been difficulty in growing the virus? Is it because of technology? Is it because of process? Is it something else? And then third of all, I would like to touch on how does the U.S. compare in getting this vaccine out with other countries, and how do our problems compare to those problems? And with that, I yield back the balance of my time.
Thank you. Full committee chairman, Mr. Waxman.
Thank you very much, Mr. Chairman. I want to thank you and Chairman Stupak for holding this joint subcommittee hearings on the H1N1 virus and how we're responding to it. The reports on H1N1 are sobering. As of last week, 46 states are now battling the disease. CDC estimates that perhaps 22 million people have been infected with H1N1, and as many as 98,000 have been hospitalized, and about 4,000 have died, including 540 children. This is a harsh reminder that we don't need a bioterror attack or other man-made disaster to threaten our health and make us worry for our children. In several ways, we have been well prepared. The federal and state governments have been preparing for a pandemic for several years. Our surveillance worked, and we're able to catch the H1N1 relatively early in its spread. Federal and state governments have developed and exercised pandemic plans. Public education has been commendable. There are 5 safe and effective FDA-approved H1N1 flu vaccines now available, and FDA has the authority for emergency use authorization to allow for unapproved but promising drugs and other products to be used to prevent and treat H1N1 flu. FDA has used this authority to make antivirals, diagnostics, and personal protective gear available in the fight against this flu. But there are clear gaps in our preparedness. We had widespread disease before we had vaccine, and vaccine supplies have been more limited than we had hoped. And at the same time, hospitals and other healthcare providers have been stretched to capacity. We know that the best way to protect ourselves from the flu, H1N1 or seasonal flu, is to get vaccinated. Because of this, the Obama administration contracted to purchase 195 million doses of H1N1 vaccine. They also picked up the full cost to the states for purchasing the vaccine. The hope was that a robust vaccine supply would arrive before infections began to soar, and everyone worked as quickly as possible to meet that goal. These hopes were not met. The past several weeks have reminded us that the process of making flu vaccines is unpredictable and challenging. Millions of chicken eggs have to be injected with virus, then the virus has to grow. Unfortunately, this virus initially grew much more slowly than anticipated, and this lag has caused most of the delay in delivering needed vaccine supplies. There's understandable frustration in the face of a growing number of infections and long lines at vaccination clinics. Parents are understandably concerned about getting their children immunized as quickly as possible. I want to make sure that everyone who needs the vaccine has access to it. At the same time, there have been unprecedented levels of collaboration among federal agencies, the vaccine manufacturers, and the states. And according to experts, the manufacturer's ability to produce a vaccine within 6 months after identifying the virus is impressive. These efforts, while significant, are not enough for those people who are still seeking immunization. And I look forward to today's testimony so that we can understand where we are in the epidemic and the vaccination effort. We also need to learn how the process can be improved, both in the short term, so that people can be protected from this disease as quickly as possible, and in the long term, so that when we face the next flu pandemic, we can be even better prepared than we have been this year. I thank the witnesses for appearing today. I look forward to their testimony. Yield back my time.
Thank you, Chairman Waxman. Next, we have the gentleman from Illinois, Mr. Shimkus.
Thank you, Mr. Chairman. I, too, want to mention our sincere prayers for those who have lost family and loved ones during this illness, and they're throughout the country, and I think a lot of districts have been affected. Information has been good, and as far as there's more people washing their hands, there's more people covering their mouths. Greg Walden mentioned staying at home, and I think that is a thing that information has been very, very helpful. Information has also been harmful, and that's this rush and this fear of people lining up for the injections or the mist sprays, and so my concern is we've got to be real about the projection of information to the public, because the public will respond appropriately. I think the rosy expectations has really caused this dilemma that we're in. The other thing that I think we should focus on is this is something that we've had a year, in essence, to prepare for. What if, in our first thoughts about a pandemic after September 11th, is there is something that we cannot prepare for? We do not know what's hit, and how do we ramp up, get information out, and then respond? I think that is as critical a question in the Homeland Security terrorist debate as responding to something we can prepare for. So there's a lot of things we can learn from in the hearing today, and I appreciate the first panel and the follow-on panel, and I think we'll be very attentive to your testimony, and I think there'll be a lot of good questions offered by members. And I yield back my time, Mr. Chairman. Thank you.
Thank you, Mr. Shimkus. Chairman Dingell.
Mr. Chairman, I thank you. And I want to commend you and Chairman Stupak for holding this hearing, which is very important. Since the initial outbreak of March of the H1N1 influenza in Mexico, the federal government, state and local public health departments, health providers, vaccine manufacturers, and many others have been working overtime to produce and distribute the H1N1 vaccine and to educate the public on precautions that can be taken to prevent the spread of the influenza. Since April 42, people in Michigan have died since contracting any strain of influenza. More than 1,200 have been hospitalized, and over 584,000 have reported flu-like symptoms. Across 48 states, there have been 3,900 deaths from H1N1 virus, 9,800 hospitalizations, and 22 million infections. The high number of deaths from H1N1, in particular the high number of pediatric deaths, has increased the demand for the vaccine, a demand that is unlikely to cease at any time soon. This vaccine first became available in the beginning of October as of November 5, approximately 35 million doses have become available. This is well below the CDC projection of 40 million doses by the end of October. There is no doubt that manufacturing a vaccine in short order is a difficult task, and this country has had difficulties with flu vaccines before. This task requires scientists to identify the virus correctly, determine the appropriate and most effective method for a vaccine, and then manufacture millions of vaccines to be distributed, all with the pressure of completing the task quickly and, most importantly, safely. I know that there are many unforeseen roadblocks for manufacturers, whether it be the difficulty in producing the vaccines in an egg-based system, a shortage of appropriate egg supply, equipment failures, amongst other things else. And while this shortfall is a disappointment, I believe we better serve the American people when we focus on producing a safe and effective vaccine and having it made available in a safe and efficient manner. History has taught us that prioritizing speed over safety is short-sighted when it comes to flu outbreaks. In February of 1976, 2 recruits at Fort Dix fell sick from the H1N1 flu strand. Congress responded swiftly. That August, a national influenza program was produced, and 1 week later was signed into law by President Ford. We were forced to deal with the costly consequences of our actions, which ultimately led to great public mistrust of immunizations as the program was mishandled and lives were lost. It is appropriate to respond to the national threats, but we need to remember to be deliberate and thoughtful and wise in our response. The H1N1 outbreak and the distribution of the vaccine provides the federal government with an opportunity and the responsibility to closely examine our pandemic response system. For HHS and CDC in particular, this means examining the way in which our government communicates with the public. For FDA, this means examining the methods in which the vaccines are approved. For many of my colleagues and for many of those testifying today, my goal is to ensure the safety and health of the public, while at the same time looking forward to how we can best prepare for future pandemics and how we can learn from the ongoing events of the day. This will include examining the national strategic stockpile and whether it is adequately supplied, preparing our scientists and manufacturers with the most effective and efficient technology to create and produce vaccines, as well as looking to whether or not the Congress has provided adequate funding for HHS, CDC, and FDA to give them the resources needed to carry out their missions. Today, I believe this hearing will be helpful in answering these questions and others. And I look forward very much, Mr. Chairman Pallone and Mr. Chairman Stupak, for working with you and for hearing what our witnesses have to say today as we seek to mitigate the outbreak of H1N1. Thank you, Mr. Chairman. I yield back the balance of my time.
Thank you, Chairman Dingell. Next is a gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Like so many other members of Congress, on a Sunday afternoon in April, the football game was interrupted with a notice of a public health emergency about a new kind of flu. We had a conference call later that day for members of Congress. I don't know how many were actually on the call, but I remember thinking at that time, our greatest danger here is not anticipating how aggressive this virus could be if we are truly faced with a novel influenza for which most of us do not have pre-existing immunity. And that's sort of where we are today. Fortunately, the story is not nearly as bad as it could have been, and many of us feared that it might be. But nonetheless, it points up some of the difficulties that have been encountered. And Mr. Chairman, I will say I'm grateful that we've had 3 hearings, but it seems to me when we were preparing for a possible avian flu, pandemic in 2004, 2005, and 2006. We had many more hearings for just the preparation for that possible pandemic than we've had after we find ourselves in the throes of this illness. Now, we do have to ask ourselves, how could we have misanticipated the ability to produce vaccine? We saw this coming. We knew it was coming. We had reports over the summer from the Southern Hemisphere that it wasn't as bad as it could have been, and yet there were some particularly vulnerable populations which would need perhaps aggressive use of vaccination protocols. And we find ourselves in our district without being able to provide even the vaccinations for those high-risk individuals. In fairness, I do want to say that I've had good cooperation from the CDC, Department of Homeland Security, Department of Health and Human Services, who came to my district in August and had a roundtable with school districts in my area so that they could be better prepared. Fort Worth Independent School District took a lot of heat last April and May for closing their school district early, but they were frightened of what might happen with not anticipating the severity of this illness. And then just finally, I do, on a personal note, I want to thank Dr. Lakey for being here for the Texas Department of Health, and he has also been good enough to do conference calls with members of the Texas delegation as we worked our way through some of the difficulties with the distributional issues of getting the vaccine where it's needed. And I will also just thank Dr. Hamburg at the Food and Drug Administration, who was kind enough to take my call after the news reports said that Texas was getting expired Tamiflu to protect its citizens. And this was one of the problems that we encountered in 2005. We produced a lot of antiviral. The illness doesn't materialize, and how long is the shelf life? And indeed, there were tests done to ensure that shelf life was longer than what was stamped on the box. It was just an unfortunate public relations aspect that we didn't correct that. But I was grateful to Dr. Hamburg for calling me and helping me through that particular public relations crisis. Thank you, Mr. Chairman, for the consideration. I'll yield back the balance of my time.
Thank you, Mr. Burgess. Gentlewoman from California, Ms. Eshu.
Thank you, Mr. Chairman, for holding this important joint hearing on H1N1 preparedness, production, and distribution. I appreciate the witnesses being here today, and I look forward to their testimony. As we've heard from our constituents or experienced in our own families, H1N1 pandemic has proven to be widespread and really highly contagious. Since the vaccine was first slated for distribution in mid-October, I, along with, I'm sure, probably all of my colleagues, have received countless calls from constituents asking when they can get the vaccine. Lines of patients have been out the door and around the block, and the news has been filled with stories of empty clinics and angry parents. Well, I don't think there's one source to point to relative to production and distribution problems. I'm interested in looking at the systemic reasons for the somewhat antiquated vaccine process we have today. For more than a half a century, the United States has been using egg-based technology to create vaccines. While it's safe and effective, it's a slow-moving process. Across Europe, vaccine developers are using the faster process of incorporating mammalian cells to grow vaccine. As we begin to explore cell-based technology, I would pose the question, will there be an adequate FDA approval process for these new vaccines? I'm also interested in hearing from the vaccine manufacturers on how they ramped up production, in some cases, to 10 times their normal production schedule. We know that production has been delayed for H1N1, a harmful but relatively moderate virus compared to something more lethal like the Spanish flu. But in the case of a stronger virus with a higher fatality rate, would our country be able to produce enough vaccine for everyone in a short time period? So I look forward to questioning the witnesses, welcome them again, learning more about how we can improve vaccine production in our country, and again thank the chairman for this joint and important hearing. I yield back.
Thank you, Ms. Eshu. Gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman.
As we look at how we're handling this latest crisis in our government, I reflect back on a few years ago when we were faced with the sudden and unanticipated problem of Hurricane Katrina, which led to an unfortunate between 1,300 and 1,800 lives lost from the hurricane and the flood itself. It also resulted in a flood of members of Congress repeatedly and bitterly attacking the administration and anybody else in town because of government's mismanagement of the whole issue. Now, of course, it begs the question, who do we blame this time for where we are? Or should we stop that game and simply get down to the business of understanding we want a painfully candid and brutally honest assessment of what is happening, what has gone right, what has gone wrong, do we have any weaknesses, and what do we need to do about it? I would hope it is this case instead that we use this hearing as an opportunity to be honest with each other. We are all deeply concerned of the thousands who have lost lives, the thousands who have been hospitalized, and quite frankly the millions who are worried that they may be affected by this latest virus hitting our nation. We recognize the incredible scientific achievements, and quite frankly I'd like to compliment the manufacturers for working so hard in trying to develop the vaccinations and the nasal systems for sending out these things to help us deal with this virus. But we still have a long way to go. And we are having this hearing today, quite frankly, because we are concerned. Something is not going right. Was it the goals are set too high, too unrealistic? Was it done somehow to assuage the worries of the public, but something we were not ready to do? Or can we really meet those goals? I'm looking forward to hearing from all the witnesses today. We have a very talented panel before us. I'm excited to hear what you have to say. But more than anything else, let's use this as an opportunity to be honest, not political, and really work for some solutions. And I yield back my time.
Thank you. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. I want to thank you for holding this hearing today. Give us an update on H1N1 vaccine production and distribution. Texas has ordered its full allocation of 3 million doses of the vaccination, but that order has not been filled due to the slow production and supply of the vaccines. I worry that states like Texas, which is the second largest state, is whether they're receiving their fair share of these vaccinations. We are a border state with, and that comes a great deal of border issues along with swift transmission of infectious diseases. I welcome Dr. Lakey, who is Commissioner of the Texas Department of State Health Services, who will be testifying on our second panel today. And he assured me that Texas is receiving its fair share of vaccinations and the state is continuing to order the maximum amount. The issue is whether the commitments of production are being met and why they are not. I'd like to highlight a piece of legislation I sponsor along with our colleague, Representative Tim Murphy, H.R. 2596, the No Child Left Unimmunized Against Influenza Act. The bill would allow HHS to perform a voluntary multi-state demonstration project test the feasibility of using the nation's elementary schools and secondary schools as influenza vaccination centers in coordination with school nurses, school health programs, local health departments, and community health care providers, state insurance agencies, and private insurers. I'm pleased the bill was included in H.R. 3962, the Affordable Health Care for America Act, that was passed out of the House. Schools are logical places to vaccinate our children. Parents can opt into the program and not have to take time off from work if to get their child vaccinated, which in a blue-collar district like ours is hard to do. Again, the issue is that why haven't the production goals been met, that we could fill the requests from the various states. And I want to thank our witnesses to be here today. And it appears that so we'll know what problems have occurred with H1N1 vaccination production and distribution and how we can fix it. And I hope we'll learn from the mistakes and hopefully make it much better. I yield back my time.
Thank you. Gentleman from Missouri, Mr. Blunt.
Thank you, Mr. Chairman, and thank you and Chairman Stupak for holding this hearing. This is an important topic, obviously, and one we ought to be concerned about. I've been concerned about both the vaccine distribution process and, frankly, the misleading overestimates of vaccine availability. I believe Mr. Waxman, the chairman of the full committee, said in his statement that the administration's hopes were not met. Well, it's apparently hope does not get the job done here. In addition to their hopes not being met, I think it's outrageous that suspected terrorists at Guantanamo Bay and Wall Street, people who work on Wall Street, were apparently slated for access to the vaccine ahead of the people that healthcare professionals said were in danger. Since October, 43 million vaccines have been made available, but that falls far short of the 159 million people considered to be at high risk because of these complications. It also falls short of the government's original projection that 120 million vaccines would be available by mid-October. In fact, just last week, the government was still estimating that 8 million vaccines were going to be shipped when only 5 million were released. I don't know how we could be this far into this process and still be 40% off in our 1 week estimate. So I'll be interested to hear the answers to those questions. In Missouri alone, there have been 60 school closings this year. Since the beginning of the year last year, during the same period, there were none. Since October the 4th, approximately 21,700 people in Missouri have possible cases of H1N1 flu. During the first 6 months of last year's flu season, there were 28 cases of all kinds of flu. And sadly, last week in Missouri, the 8th person died from complications with H1N1. I want to know, and the people I work for want to know, where this problem met its failure to understand the problem, to recognize the problem, to move forward with the problem. And with vaccine delivery, how long ago did we know that the vaccines were not going to be available, and what could we have done about it? And, Mr. Chairman, I expect some of those questions to be answered today, and I'm grateful to you for holding this hearing.
Thank you, Mr. Blunt. Gentleman from Pennsylvania, is he there? Oh, yeah, gentleman from Pennsylvania, Mr. Doyle.
Thank you, Mr. Chairman, and I want to thank you for holding this hearing on the issue of H1N1 preparedness at such a relevant time. As the Centers for Disease Control has recently reported, the H1N1 strain has now claimed over 4,000 lives since April of this year. Of those, over 500 were children. I'm very sad to report that just this past week, a newborn baby died at Children's Hospital of Pittsburgh, located in my district, of suspected H1N1 influenza. If confirmed as being an H1N1 death, this will be the first reported infant death. In the state of Pennsylvania alone, 9,600 cases have been reported, nearly 1,800 of them in my congressional district. This is indeed a very serious problem. This pandemic is different than what we're used to dealing with every fall, as the target's an unlikely and unusual population. This strain is mostly affecting younger people, with more than 70% of the reported cases in Pennsylvania involving people under the age of 25. Antivirals are playing an increasingly important role in fighting this epidemic, and I'm happy that the FDA has recognized this by issuing emergency use authorization for intravenous administration of these potentially life-saving drugs. I do have serious concerns about the reports of the difficulty doctors have had in obtaining enough vaccines for their patients, and I'm anxious to hear our witnesses testify to this. This year's distribution plan for the vaccine was unprecedented, and I'm extremely interested in the opinions of our panel of its effectiveness. I think that this hearing will serve as an important venue to hear from all sides of this issue and help us all work together so that in the future we know what works and we know what must be improved upon. I look forward to hearing from our witnesses, and I want to thank you all for your testimony today. And again, I want to thank the committee for holding this important briefing, and I yield back.
Thank you. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. Done a disservice to these young mothers because you all knew this was coming, appropriate preparations were not made, and these are some of the questions we're going to want to get to today. I want to talk with you about the delays and what you think has caused those. The communications processes, where the breakdowns have been between you all and HHS, because we had different messages that were coming out. That's confusing to the public. I think also the processes that were in place for approval, for distribution, and then certainly looking at the diagnosis, confirmation. portion of that. And then let's talk about lessons learned and how we moved forward. And Dr. Shukat, I had pulled a Reuters article, a comment you made in here where you say, I think the key barrier to our immunization effort is really the fragility of the public health infrastructure. I'd love to explore that comment with you. Thank you all. Thank you, Mr. Chairman. I yield back.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. So far, there have been 3,900 deaths in the U.S. From the H1N1 flu, with 266 deaths in California. This compares favorably. It is less than annual deaths that are expected from the seasonal flu. I suppose that's good news, but I agree with Chairman Waxman that this is our rehearsal for a major terror attack from some sort of biological weapon, and I think our grades are very mixed. In terms of preparing the public, I think we have done very well, and I commend the panel and I commend others in our federal government for making the case calmly and providing lots of details for what the public is supposed to do. I'd give that an A. In terms of preparing the vaccine, we've had a lot of mixed results, and I suppose that could be a B-. But in terms of distributing the vaccine, I would give us a D-. And a lot of that is the lack of preparation to states and localities for exactly what they should do with scarce resources. I was personally scared because I have a pregnant daughter-in-law who had to spend weeks in New York City finding a doctor who had the vaccine. She did get vaccinated. But in my district, the Beach Cities Health District, one of the first providers able to offer the vaccine, had a drive-in event recently. People drove more than 100 miles from as far as Santa Barbara and San Diego, turning what was supposed to be a local event into a regional scramble. The line of cars leading to the clinic backed up for miles, the police deployed to manage the unexpected crowds, and all this mayhem was just for 3,000 doses of vaccine. It was a disaster, and now other areas are not doing the same thing. As my time expires, the distribution piece was a failure, and I hope our witnesses have learned from this and that we will move forward much more effectively. Thank you, Mr. Chairman.
Thank you, Ms. Harmon. Gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. Today, the Subcommittee on Health and the Subcommittee on Oversight and Investigation will have an important opportunity to shed some light on our government at work and what is a matter of life and death, and hopefully we be able to gain a few answers to the many questions our constituents have asked us about H1N1 preparedness and the Obama administration's response. Mr. Chairman, from fiscal year 04 to 09, this Congress appropriated almost $7 billion for pandemic flu preparation. Congress also provided an additional $6.4 billion in the FY09 supplemental, bringing the total since fiscal year 04 for pandemic flu preparation to almost $13.4 billion. Without question, the promotion of the public health and safeguarding the lives of all Americans is an important national priority. But we also have a solemn duty to thoroughly scrutinize every dime we appropriate, because every single dime is one more IOU that will be thrown upon the backs of our children and our grandchildren, likely for decades to come. Both the American people's physical health and fiscal health have to be priorities for this Congress. Mr. Chairman, I make this point because I have concerns about this government's response to H1N1, and I believe that it may be a microcosm of what's in store if the health care legislation that this House passed 10 days ago becomes law. When this government prioritizes KSM, Khalid Sheikh Mohammed, to receive a vaccine, when this government has enough vaccines for Guantanamo Bay, but not enough for Grandma K, we have a big problem. Is this what the American people expected? Is this what the American people deserve? At the same time, this Congress continues to put them and their children further and further into debt. Mr. Chairman, I think not. I hope that today we'll be able to pull back the curtain for the American people so they can see how the government attempts to manage their health and their collective pocketbook. And I yield back.
Thank you. Gentleman from Arkansas, Mr. Ross.
Thank you, Mr. Chairman. I'd like to thank the Chairman and Ranking Member for having the Energy and Commerce Committee hold today's hearing on H1N1 preparedness. Over the course of this year, we have seen the strain of influenza spread to a global proportion and lead to a declaration of national emergency. According to the CDC, as of November 13, 2009, influenza activity was widespread in 48 states, almost all of which is likely H1N1 influenza. Furthermore, there have been 9,800 hospitalizations, 22 million infections, and 3,900 deaths from the H1N1 virus, 540 of which have been confirmed pediatric deaths. Both public and private sectors have attempted to work together in an expedited effort to ensure adequate vaccine production and delivery to patients. Unfortunately, such efforts have fallen short. We have seen major delays in access to this much-needed vaccine. As a result, we have thousands of individuals, including those in high-risk categories, still waiting for the vaccine as we fight this pandemic. I'm also deeply concerned about the impact of H1N1 on our children and our schools. During seasonal flu outbreaks, 95% of deaths are usually among those older than 65, but for the swine flu, 95% of the deaths are occurring in those younger than 65, and typically among those far younger than that. My concern is that every parent who wants to get their child vaccinated should have the opportunity to do so. The delays in getting the vaccine to the American people must be addressed and fixed now. Clearly, there are problems with the current process in place that could have been prevented. The public deserves answers as to why there is such a shortage in supply of a vaccine when H1N1 has posed such a serious health threat for months. I look forward to hearing answers to this and other related questions. And with that, Mr. Chairman, I yield back.
Thank you. Gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman, and thank you, Chairman Stupak, for convening this joint hearing. I'm sure that all of us have received phone calls and emails from anxious parents wondering if they will be able to obtain the H1N1 vaccine for their children. I'm sure we've all been stopped by constituents back home wondering when the vaccine will be available in their area and worried that there is a shortage. Today, we will hear from the government departments and agencies tasked with responding to the H1N1 pandemic and from the manufacturers of the vaccine itself to determine how much vaccine has been produced and how much more is on the way and how it is being distributed and allocated. I also anticipate that we will hear suggestions for how production and distribution could occur more smoothly in the future. On our second panel, I would like to specifically welcome Phil Hosbach, Associate Vice President of Immunization Policy and Government Relations, the head of the Sanofi Pasteur's Global Influenza Pandemic Crisis Team, the U.S. headquarters for Sanofi Pasteur's in my home state of Pennsylvania. The Pennsylvania site is also the only domestic manufacturing site of injectable flu vaccine, and the employees there have been working around the clock to produce both seasonal and H1N1 influenza vaccines. I would also like to welcome Paul Peralt, President of CSL Biotherapies, which has its headquarters in King of Prussia, Pennsylvania, right outside my district. Mr. Chairman, again, I thank you. I look forward to hearing the testimony of all of our witnesses, and I yield back my time.
Thank you. The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman, for holding this very important hearing. I want to highlight three issues that I hope our witnesses will address according to their expertise during our hearing this morning. Clearly, a thorough response to any public health emergency, such as a flu epidemic, requires a partnership between local, state, and federal public health agencies and labs. And I'm concerned about resource shortages at the state and local level, particularly with regard to personnel and modern information technology and communications. I have a bill on that matter and would like to hear your insights on how those resource shortages have affected our response to this flu H1N1. Secondly, I'd like an update on the state of innovations and improvements that many of my colleagues have referenced that will help us do a better job next time. Cell-based manufacturing technologies, the use of adjuvants, and alternative methods of vaccine delivery beyond injection or nasal sprays. And lastly, and I think most importantly to me, I'd like the witnesses' comments on our lack of domestic manufacturing of H1N1 and seasonal flu vaccine. This is of great concern to me, and I asked this of our Secretary of Health and Human Services when she last appeared before the committee. It appears that we have 5 contracts with 5 manufacturers for H1N1 vaccine. Only one does its bulk manufacturing in the United States, in the state of Pennsylvania. I think that if we were to ever face a much greater flu that presents much greater virulence, it would be a question mark whether we would be able to get supplies of vaccine from production sites in other countries. Any country that hosts vaccine manufacturers would want to assure that their own population was protected first before permitting the export. And so I'm very concerned about the lack of domestic manufacturing presence and would like your comments on that. I yield back.
Thank you. The gentleman from Oklahoma, Mr. Sullivan.
Thank you, Mr. Chairman. Thank you for holding this joint hearing today on the national H1N1 swine flu preparations, especially on the current status of the vaccine production and distribution. I'm interested today in examining the lessons learned from both the administration and vaccine manufacturers in terms of responding to this national public health emergency. To date, manufacturers have delivered 48.5 million doses of H1N1 vaccine, and the Department of Health and Human Services has hoped to have as many as 120 million doses by now. Obviously, there is a large gap between the administration, what the administration had promised and what they were able to coordinate and deliver. I'm concerned that the administration's plan was overly optimistic and that this has led to confusion with the American public. Since September 1, 890 Oklahomans have been hospitalized due to complications from influenza, and 27 persons have died. 90% of the H1N1 related deaths have been persons less than 65 years old. Health officials in my state announced yesterday that all Oklahomans who want to reduce the risk of H1N1 infection are now eligible to receive H1N1 influenza vaccine. While vaccine supplies are limited, demand from priority groups has dipped to a point where all Oklahomans can begin to receive vaccine. H1N1 influenza activity has been widespread in Oklahoma since early September, and even throughout, though statewide monitoring has recently shown a decline in influenza-linked hospitalizations, this virus is expected to circulate throughout the winter months. The possibility also exists that another surge of H1N1 flu may follow the current one, and we need to be prepared for this contingency. I look forward to hearing the testimony of our witnesses today and examining how we can continue responding to this public health emergency. And I yield back the balance of my time.
Thank you. The gentlewoman from Florida, Ms. Castor.
Well, thank you, Chairman Pallone, and good morning to our witnesses. The CDC and Secretary Sebelius and all of you have done exceptionally well in your public health outreach. You have kept Americans informed about the risk and basic prevention methods to combat the spread of the virus, such as hand washing and the use of alcohol-based sanitizers. And I appreciate Secretary Sebelius's visit to Florida last week. She visited the East Manatee Family Health Care Center in Bradenton, Florida, and we met personally with representatives from the health department, community health centers, and other providers throughout the area to review local distribution of the vaccine, particularly to people in the high-risk categories like pregnant women and young children and others with asthma and diabetes. My greatest concern right now is the spread of misinformation, especially on the Internet. Just over the past weekend, I was talking with a doctor who I know who works in Tampa General Hospital. He's married to an OBGYN, and they were explaining to me that they're running into the problem of pregnant women and other in high-risk categories that have read something on the Internet that has discouraged them from receiving the vaccine. And after talking with them, I went online to see what is out there, and they're right. There's a lot of misinformation on the Internet One website calls it a complete load of nonsense that mainstream media and American public health officials state that the benefits of H1N1 vaccine far outweigh the risks. They're frightening pregnant women who are at high risk to think that they might miscarry if they're vaccinated. This website reports that the vaccine is responsible for death, paralysis, seizures, and other ailments. So we've got our work cut out for us. But it doesn't stop there. In September, a major cable news network did a segment with a so-called infectious disease expert advising parents not to vaccinate their children and declared that he would not vaccinate his own children, claiming that the vaccine and others are not safe and they cause more serious, devastating conditions. So in your testimony, will you please address how we can effectively combat the spread of misinformation and continue to empower communities with accurate information and continue to encourage those, especially in the high-risk categories, to receive the vaccination? Thank you. I yield back.
Thank you. A gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Chairman Pallone and Stupak. I wanted to put on the record the effective manner in which my state of Illinois is handling the H1N1 flu vaccine and administration. The Illinois Department of Public Health has an H1N1 specific website that contains a wealth of information about vaccine availability and prevention information. The City of Chicago set up 6 free clinics to administer H1N1 vaccines at city colleges. Chicago vaccinated nearly 51,000 people in the 7 days following the opening of the free clinics. There are a number of issues surrounding the infection and death rates in Illinois that lack sufficient explanation. Maybe you have these answers. Why is the highest number of H1N1 deaths among adults aged 25 to 29? These numbers defy all the things that we previously knew about flu viruses. Do we have the correct distribution system? Is giving the vaccine to banks and companies like Goldman Sachs and NBC the best way to distribute the vaccine? Our current lack of research data limits our ability to draw concrete conclusions, and if we're unable to draw conclusions, there's no way we could construct an adequate or effective response plan, which only increases all of our risk. So I hope to hear about the public health plans and research efforts underway to help us better understand the disease and innovation, prevention, and treatment methods that are emerging. I thank all of the witnesses for being here today to help shed more light on the situation, particularly as we're learning new information every day, and I look forward to your testimony. I'll yield back.
Thank you. The gentleman from Utah, Mr. Matheson.
Well, I want to thank both Chairman Stupak and Pallone for holding this hearing today. My state is not unlike my colleagues here on the committee. We've had our outbreaks of H1N1 in schools and communities. We've seen over 623 hospitalizations due to the influenza this year, as well as 14 deaths. Our state has worked with the federal government and manufacturers to make as many vaccines available as possible to our residents, and I'm looking forward to hearing how we can better improve our strategy and coordination for responding to this public health crisis. To date, my state of Utah has received a total of just over 296,000 doses, and providers have reported having administered just over 176,000 doses of the vaccine as of November 7th. While our state supply of vaccine continues to arrive in weekly shipments, the vaccine is still in limited supply. I represent the state with the youngest population in the country, so I'm continue to be worried about making sure our children get access to this vaccine in a timely fashion. I'm also concerned by several recent reports in the uptick of counterfeit medications. U.S. Food and Drug Administration has issued warnings to consumers to use extreme care when purchasing any products over the Internet that claim to diagnose, prevent, treat, or cure the H1N1 influenza virus. The agency issued this warning after the FDA recently purchased and analyzed several products represented online as Tamiflu. The FDA notes on its website that one of the orders, which arrived in an unmarked envelope with a postmark from India, consisted of unlabeled white tablets taped between 2 pieces of paper. When analyzed by the FDA, the tablets were found to contain talc and acetaminophen, but none of the active ingredient. I'm working on legislation to proactively address the rise in counterfeit medications with my colleague, Mr. Bouyer. Counterfeiting is a lucrative business, and I hope that my colleagues will proactively work with me to address this issue with any drug safety legislation to come before this committee. Thank you, Mr. Chairman. I'll yield back the balance of my time.
Thank you. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman, for conducting this important hearing. We've heard today already a couple of allusions to Guantanamo Bay and I think one to even Katrina. And I'm as concerned as anybody about the specter of Khalid Sheikh Mohammed getting this vaccine before my son. And I guess I'd like your assessment as to whether that is in fact happening. But more importantly, I think it's important that we understand what we can do as a legislative body at this point to enhance our ability to manufacture and distribute the vaccine in a better way. We've obviously seen far too many deaths across the country, certainly Ohio, and my congressional district has been no exception to that. I'd also be interested in hearing your opinions concerning other ways that we can combat this H1N1 epidemic, apart from administering the vaccine. My colleague from Florida referenced the misinformation campaign that seems to be occurring out there. I'm curious as to the educational component that we can promote. Simple things like hand washing and things that our constituents can do to put themselves in a better position. And finally, your assessment as to those who are most likely to get sick and die if they contract the virus, what they can do in particular. Diabetes, I understand that the obese have a particular risk factor, and how we can, again, from a legislative perspective, at this point in time, do everything we can to maximize our ability to combat this troubling epidemic. Thank you, and I yield back my time.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, and I appreciate you holding this hearing today. So much has changed since this committee held its first hearing on H1N1 back in April. At that time, the H1N1 flu was just breaking, and there were only 91 confirmed cases in the U.S., including a young boy in my district. There was also no vaccine, and the government was just beginning to formulate a federal response to the growing pandemic. So we have traveled some distance since then. Now, nearly 8 months later, over 22 million Americans have had the H1N1 flu, and there's a vaccine in production, as we all know, and it's being distributed free of charge to the American people. However, there have been challenges along the way, and we've heard that discussed here today, with manufacturing and distribution of the vaccine. And because of the slow rate of vaccine production, demand has outpaced supply, and the vaccine remains difficult for people to obtain. It's difficult even for those in high-risk populations sometimes. So it's very important that we have this hearing and we figure out ways to address these challenges that we're facing currently and the ones that may be ahead. You know, we've seen moms with young children and pregnant women and the elderly standing in lines and hoping to get the vaccine, and we want them to get it. We've heard the reports of Wall Street employees having access to the vaccine, and it certainly undercut the public's confidence in the distribution process, which is important. And it's important that we correct the record so that people understand what is and isn't happening. But it's also just critically important that we do everything we can to effectively deal with H1N1 from this point forward. And frankly, this won't be the last flu challenge that we have, so that we can formulate the proper way to respond to these kinds of challenges in the future. I yield back.
Thank you. The gentleman from Indiana, Mr. Boyer. Pass. Gentlewoman from Colorado, Ms. DeGette.
Thank you very much, Mr. Chairman. I want to thank both of our chairmen for having this hearing today. I'll submit my statement for the record because I'm sure every single thing I had in there has been said by other members of the committee. But let me just say this. The Oversight and Investigations Committee has had a number of hearings over the years on flu pandemics. The good news about what has happened with this pandemic is our public campaign, our awareness has been terrific, as Congresswoman Harman said. The problem is we still do not have an alternative to the egg-based vaccines. And we were assured at the September 15th hearing that we had that we were ramping up production, we knew H1N1 was coming, and those vaccines would be readily available very, very soon. That obviously has been the big problem with our response to this pandemic. Now, it's not so bad because, as it's turned out, this particular strain, while fatal, and we feel badly about the fatalities that we've had, is not as virulent as, say, the avian flu. But I'll tell you what, if this had been a virulent flu strain like the avian flu, we would have millions of casualties already. Now, my own daughter, who's a type 1 diabetic, spent weeks going around Denver trying to get a vaccine, only to finally get it last week. And I've got to say, over the 13 years I've been on this committee, we have got to fix this problem. We can't wait till we have the next pandemic to say that we've got to get an alternative to egg-based vaccines. And so again, to both of our chairmen, I want to thank you for having this hearing. And I want to say that at least this member of Congress intends to keep pushing, even when this is out of the headlines, to make sure we find these alternatives. Because if we don't, it'll be on our shoulders the next time we have a pandemic, and it's a virulent pandemic that causes millions of deaths. So I intend to do everything I can to make sure that that will not happen the next time.
We thank the gentlewoman. Next is the gentleman from Connecticut, Mr. Murphy.
Thank you very much, Mr. Chairman, to Chairman Pallone and Stupak. I appreciate this hearing today. I appreciate it especially as a parent of a current 15-month-old H1N1 patient at home. He's doing fine, but I'm looking forward to the testimony today for a number of reasons. One, I think that this conversation about how our federal government is interacting with state governments is important, and I know you're going to spend some time talking about how you turn your recommendations for distribution systems into best practices. But I'd also like to hear about your interactions with states regarding preventative measures. We've had a number of long-term school closures in Connecticut due to outbreaks, and I think one of the difficult things for local school districts has been an inability to really get the best information regarding how they should approach small or larger-sized outbreaks in school systems, in daycare settings, and so I think a lot of us would be interested in hearing about how you're disseminating those recommendations down to school districts and to other settings in which you have a lot of kids. And second, just to partner and build on the remarks of Representative Baldwin and Representative DeGette, I think a lot of us are very interested in the progress we're making this season, but also for next season on alternative processes. I know that HHS has already given out some fairly large research grants to companies, one actually located in my district, Protein Sciences, to start building some non-egg-based processes that have, I think, some real potential. And I'm interested in whether you think any of those processes might come online this season, or whether we're looking out into the next outbreak or to the next season for some of these alternative processes. But again, I think there are a lot of questions, but I think that you've answered many of them so far. I think you've done a great job in disseminating information, getting information out to the public, and I think that this hearing can just help you build on that. I yield back.
Gentlewoman from the Virgin Islands, Ms. Christensen.
Make me a list of who's not on it. Okay. Well, yeah, but get me a list of who I need to get. Yes, hear you.
The gentlewoman passes. Gentleman from New York, Mr. Wien.
No, she's from
mic?
Oh, her mic is not working. I'm sorry.
Is this one working? Yeah.
Okay.
Thank you, Mr. Chairman.
Thank you.
And thank all the chairs and ranking members for having this hearing. As a physician and a former public health administrator, you can imagine that this issue is of great concern. And as someone who's managed emergencies in the past, I know how important communication is and managing them and controlling panic and controlling the spread of the disease in this case. Since the spring, when we were first made aware of the H1N1, it's now widespread, I think, in 48 states and at least 2 territories. As of the last report, there are 80 cases in the Virgin Islands. I'm sure there are more now, 1 death, and 444 cases with 34 deaths in Puerto Rico. And I'm very concerned that half of the children that died from H1N1 between April and August were African American and Hispanic children, which is considerably more than the percentage that both groups represent in their population. So I'd like to hear something of what is being done to outreach to those communities, as I have asked before. I want to say that several years ago I introduced the Rapid Cures Act, which would increase research to shorten the time from bug to drug and vaccine. I didn't introduce it in this Congress because I was assured that the research was being done and I thought we'd be further along, but the shortage shows that we're probably not, and I'm hoping also that the limitations that we've faced in providing adequate vaccine will yield valuable lessons going forward, and I look forward to the testimony of our witnesses.
Thank you. Mr. Weiner.
Thank you, Mr. Chairman. Mr. Chairman, I want to thank the members of the panel both for their work and for being here today. I represent the community around St. Francis Prep, which represents, I guess, the closest thing to the American ground zero for this virus. You know, frankly, this is the problem of trying to deal with a complicated health thing in the context of 24-hour news and a lot of people who look at this through the lens of their own experience. We have swung wildly from pole to pole between this is an enormous problem that is going to smite us all to this is not that big a deal. We have the very same people who have been traveling the country saying, get government out of our health care, are now saying, how come government isn't doing a better job with our health care? I certainly hope that you've had a strong and stern talking to those viruses that refuse to grow fast enough. I hope that any of those viruses that haven't been performing have been summarily dismissed. And I look forward to an oversight report by the GAO about how it is that we're recruiting a virus that does such a poor job of growing in chicken eggs when we ask it to. But the bottom line of all of this is, to some degree, we've all participated in a small way to dealing with this notion of frenzy around this. Even the Vice President of the United States, I think, probably regrets saying he would recommend his family members not get on a subway in New York City, where you can catch things, but I'm not sure swine flu is going to be at the top of your list. The point is that we, to some degree in government, we, too, exaggerate our ability sometimes to be able to be a fulcrum against Mother Nature and the laws of medicine and, some degree, chemistry and physics and the like. And I think that you should be commended for trying to keep a level conversation tone here, even in the face of many different cross-currents. We should try to learn each time we have one of these instances what we can do better. And I think to some degree a lot of what you've done now is based on lessons that have been learned. But I think that it's also important that we as the legislative branch empower you all to do the job you can and then do our best to give you the elbow room to try to make smart medical decisions in what is an environment that is often hyper-tense, hypersensitive, and often polluted with a lot of misinformation. So I appreciate your being here to help us do that.
Thank you. The gentleman from Georgia, Mr. Barrow.
I thank the chairman, and with my thanks to the witnesses for their participation, their work, and the testimony, I'll waive an opening.
Gentleman from Iowa, Mr. Braley.
Thank you, Mr. Chairman. It has been a long time since the word smite has been uttered in this hearing room. And unlike my youthful colleague from Connecticut, my 3 children are in another high-risk category, college students. But I'm very concerned about the delay in productions of vaccine and the shortages of both the H1N1 and the seasonal flu vaccine and the process of vaccine distribution. There have been severe shortages in my state of Iowa, which, by the way, is the #1 egg production state in the country, and I'd like to speak out on behalf of all eggs who've been criticized. Vaccine shortages that led to the cancellation of flu shot clinics in my state left thousands of Iowans without access to the flu vaccine and left them vulnerable to the virus. And as of last Friday, the Iowa Department of Public Health had confirmed 19 H1N1 related deaths in Iowa, including 1 child and 18 adults. And those victims include people from Dubuque and Black Hawk counties, both of which are in my district. And more than 500 Iowans have been hospitalized with the H1N1 virus. That's why you can imagine how outraged I was to learn a couple of weeks ago that some of the biggest companies in New York, my apologies, Mr. Weiner, including Goldman Sachs, Citigroup, J.P. Morgan Chase, and Time Warner, were receiving large doses of this vaccine for their employees. I don't think that it's appropriate or fair that big Wall Street firms be given priority access to the vaccine while thousands of Iowans are going without it. I sent a letter on November 5th to Secretary Sebelius expressing my serious concerns about the distribution process and urging her to ensure that the vaccine is distributed based on risk and need, not based on wealth or profession or zip code. I haven't received a response to my letter, so I hope that you folks today can shed some light on this process, what additional corrective measures, if any, have been taken, and explain to me and my constituents why these companies were receiving the vaccine when so many of my constituents were forced to go without. And I'm talking about seniors, immunocompromised individuals, and children. I look forward to hearing the testimony of the witnesses today and learning why the Iowans that I represent who would like to receive these vaccines and would like to receive them soon will receive access, and what is being done to promote expansion of the availability of the virus. So thank you.
Gentleman from Maryland, Mr. Sarbanes.
Thank you, Mr. Chairman. I'll be very brief. We're looking forward to your testimony. I'll be curious to hear you describe where things have gone compared to where you thought they would be the last time we had a hearing. Sort of at the beginning of this process, you made projections. You talked about certain contingencies. And I'd be interested to know how the advance of the disease has panned out against those original projections, because it helps us make judgments as you project further, and that would be both with respect to advance of the disease and with respect to the way we're responding to it. And I just want to echo what Congressman Braley just said, and that is if there are going to be delays in the distribution, and if what's been manufactured is less than what we hope to have at our disposal at this point in time, it becomes even more critical. I mean, it's always critical that the distribution be done in a fair way, but it becomes even more critical that it be done fairly, because the larger context is that there are shortages, and it makes people, I think, much more resentful, and rightly so, when they see an unequal distribution and one that's not occurring according to the criteria that you've laid out. So I think there's probably a lot of interest in having you address that in your testimony, and I yield back my time.
Thank you, Mr. Sarbanes. Mr. Engel.
Well, thank you very much, Mr. Chairman, and I too will be brief. I'm delighted that we are holding this hearing this morning, and I look forward to listening to the witnesses. Obviously, what's going on with the swine flu is something that Americans are asking lots and lots of questions. We're hearing that this is something that is easily spread, and yet we were told several months ago that there would be adequate vaccines, and there aren't. And I know people have been contacting my office to find out where they can get vaccines. And I think what happened here is that people's expectations were rising when the government announced that there would be no problem and people would have enough vaccines for use. I think if that had not been stated or said, perhaps people's expectations wouldn't be so high, but the double whammy of not having enough vaccines plus the announcement that there would be enough for people has made people think that something is terribly wrong. I've had some discussions with some of the people testifying today, and they have helped me to understand what's happened, but I think that we really need to ensure that something like this really never happens again. I know that people in my district have been wondering. My staff director had his two little boys just last week, both come down with swine flu, and people have been calling my office and wanting to know where they can get vaccinated, and we've been trying to help them the best we can, but people are confused and angry at the same time. So I look forward to the testimony and to hear what the witnesses have to say, and I thank you, Mr. Chairman, for holding this very important hearing, and I yield back.
Thank you, Mr. Engel. I believe we've concluded our opening statements, so we'll now proceed to the witnesses. Let me call or introduce the first panel. Starting with my left is Dr. Ann Schuckett, I hope I'm pronouncing it right, who's director of the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. And then we have Dr. Nicole Lurie, who is the Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. And finally, Dr. Jesse Goodman, who is Chief Scientist and Deputy Commissioner for Science and Public Health for the Food and Drug Administration. Now, in accordance with the policy of the Oversight and Investigation Subcommittee, I have not done this before, but because of the policy of the Oversight and Investigation Subcommittee, all testimony at today's hearing will be taken under oath. And I am to advise you that you have the right under the rules of the House to be advised by counsel during your testimony. And I have to ask you initially if you wish to be represented by counsel, and if so, you would have to state their counsel's name. Dr. Schuckett?
No, thank you.
No. Dr. Lurie?
No, thank you.
You said no? And Dr. Goodman? No. Okay. So then we're going to stand. Each of you should stand. We're going to take an oath. Well, you're going to take an oath, I should say. You raise your right hand to take the oath. You swear or affirm that the testimony you are about to give is the truth, the whole truth, and nothing but the truth. Let the record reflect that the witnesses replied in the affirmative. You are now under oath. Thank you. And we'll start with the opening 5-minute opening statement from Dr. Schuckett. I think you all know that you can submit a longer statement for inclusion in the record, but we'd like you to try to stick to the 5. Thank you.
Thank you, Chairman Pallone and Stupak, Ranking Member Walden, and members of the subcommittee. I'm really pleased to be back to talk with the committee about our comprehensive response to the H1N1 pandemic and to answer your questions. A brief update on the situation. As you've heard, we released new estimates for the toll the virus has taken in the first 6 months of the pandemic, 22 million infected or ill, 98,000 hospitalized, and sadly, almost 4,000 deaths. The virus is spreading in considered widespread in 46 states. In many areas, it is beginning to decrease the burden of illness, but in some, it is still on the upswing. There's been no change in the illness pattern, still disproportionately a younger person's disease, many people with underlying conditions or pregnancy disproportionately affected with severe complications. So far, no change in the virus. It hasn't become more virulent or changed genetically. We still think the vaccine is an excellent match with this virus that's circulating. But unfortunately, the trajectory that the virus will have is unpredictable. We do not know how long this wave will last, whether there'll be multiple waves. We know that flu season can last until May, usually. We don't know how much seasonal flu strains will have, many unknowns, and that makes it even more important that we strengthen our response. Without the investments of Congress in preparedness and strengthening our ability to cope with a pandemic, we would be in much worse shape than we are today. I'll go through CDC's response and others will talk more broadly. We rapidly identified and characterized the virus. We developed candidate vaccine strains. We carried out epidemiologic and laboratory surveillance in the U.S. and abroad to understand what was going on and direct our interventions. Our aggressive response has been science-based. We have rapidly deployed life-saving antiviral medicines and other material from our strategic national stockpile. Laboratory kits were prepared in record time and disseminated to all of the public health labs here in the U.S. and to 150 other countries. We deployed field teams to support the state and local response and continue to support the state and locals in what is very much an implementation effort at the front lines. We've issued science-based guidelines on prevention and mitigation. We expected disease to increase this fall before a vaccine was available, so we worked very actively with other sectors to make the best use of antiviral medicines in high-risk people or in severe illness, to work with education on ways to better intervene in schools without as disruptive effects as we saw last spring. We've focused on businesses and healthcare workers and so forth. Communication has been a priority for all of us, and we've done outreach with new media and old media and many partners. Of course, the heart of our response is the vaccination effort right now. It's been unprecedented in its speed with which we've gotten this vaccine, but of course, like everyone, I'm disappointed in the initial production, and we've been held captive really to this slow-growing virus. However, today I can announce that there are 49.9 million doses of H1N1 vaccine that are available for the states to order. It's not as much as we wanted to have by now, or frankly what we needed to have by now, but every dose that's coming out is being rapidly moved to places where it can go into people and and help protect them. At CDC, we worked to develop recommendations to prioritize the use of scarce vaccine for those at highest risk of disease or most likely to spread. We have a distribution system that gives each state a pro rata population-based share of the vaccine, trying to have as fair a process as possible. The states and local health authorities are the implementers. They are deciding where that vaccine gets shipped. They are working very closely with the provider community, the local health departments, hospitals, with community health centers, with others, schools, for instance, where vaccination efforts can go forward rapidly. 34 states so far have initiated school-located vaccination efforts to really reach large numbers of children promptly. Not as many have been able to be completed because of the supply, but more are happening every day, and we know that the state of Maine expects to finish their school-located program by the end of this week. We have done all this mindful that the environment we live in makes communication and emphasis on the safety of vaccines for the forefront for many. And so we've done this without cutting any corners on safety and have strengthened our safety monitoring system to address any unanticipated problems. We're working hard with partners across government and in particular with the state, local, and tribal authorities who are directing the program where they are. They have been working tirelessly to make this succeed, and I'm happy to detail some of the efforts they've been making in the comment period. When we have the opportunity to look back on this public health challenge, we'll have time to reflect on the remarkable scientific accomplishments that made it possible to rapidly detect and track a previously unseen virus and get a vaccine developed in record time. We'll have time to more systematically search for lessons in production and delivery that we can apply in a future pandemic and to rebuild the public health system that we all rely on. But today, we need to quickly adapt from our recent experience and maintain our focus on the days, weeks, and months just ahead. We will have more vaccine to put in the path of this virus, and it is our commitment to continue to work closely with our state and local public health partners to ensure that it is as effectively delivered to those who need it most. I'll look forward to answering your questions.
Thank you, Dr. Schuchat. Dr. Lurie?
Thank you. I, too, am very pleased to be able to talk with you today about our pandemic response.
Maybe put that mic a little closer to you there. Or,
is it better?
Yeah,
and
talk
first,
into it directly
if
you can.
For your foresight in helping to rebuild our country's vaccine infrastructure. As a result, when we decided to pursue vaccine for the H1N1 this spring, we had pre-existing contracts with manufacturers already licensed in the U.S. to get us out of the blocks quickly to contract for manufacturing vaccine. And preparedness efforts have helped hospitals and healthcare systems also be ready. My office has a fourfold response related to this pandemic. First, to coordinate a cross-department response and work with the interagency. Secondly, to stimulate the development of and contract for vaccines and antivirals. Third, to monitor and ensure that we can backstop states and communities if they get overwhelmed and request our help. And finally, to stay prepared for any other emergency, not to take our eye off the ball. This whole response has been a public-private partnership from the get-go. Starting with vaccines, as you know, we developed a new vaccine with unprecedented speed, and this was really made possible by investments in basic and clinical science, manufacturing, regulatory processes, and would not have been possible at all without our partnerships with industry. And while modest amounts of vaccine came ahead of schedule, as the graphic over here details on the left, a combination of poor production yields, late completion of seasonal vaccine, problems with new filling lines, decisions on the home country of one manufacturer caused delays in the availability of vaccine, not just for the U.S., but around the world. And while the number of doses that's been produced and distributed in ministers continue to grow, we remain vigilant. To ensure a steady supply of vaccines, we talk with manufacturers almost every single day. We constantly monitor the progress of every lot produced, working to make up ground wherever possible. And right now, we have full-time staff in the facilities of 2 of the manufacturers. In addition, Secretary Sebelius and I have spoken directly with CEOs, actually on several occasions, seeking to identify opportunities to work together to be sure that there are no arcane kinds of obstacles in the way. And while these delays are really frustrating to everyone, we do need to remember that the virus is the real enemy here. And the way forward, as we've been talking about this morning, is to improve our country's domestic manufacturing capacity using newer, faster, and more predictable technologies so that the virus of the future does not defeat us. Antivirals have been another critical aspect of our response, and I just want to point out that we've supported the development of new antivirals, issuing the first emergency use authorization for an intravenous antiviral, and we have procured over 30,000 doses across 3 types of antiviral drugs. We're also focused on ensuring the healthcare system and communities throughout the country remains able to care for those who need it. CMS can now grant 1135 waivers to decompress hospitals and other facilities when they're getting overburdened, letting them use those emergency plans. And we stand ready to deploy federal assets when necessary, including vaccination teams, clinical and laboratory staff, and temporary medical facilities. And our first ever vaccination team is headed to Delaware to do just that. We've also partnered closely with the private sector healthcare system, including health insurers, pharmacists, big box stores, the AMA, and the public health community, to find ways to pay for vaccine administration so cost is not a barrier to people who want to be vaccinated. Let me shift for a minute to lessons learned. Clearly, the support of Congress in the past few years has been critical in enabling us to respond so quickly to this pandemic. And yet it is clear the chronic underinvestment in public health, whether at the federal, state, or local levels, or in the manufacturing infrastructure, has real-world consequences, and we cannot afford to let this happen again, ever. While we've made vaccine in record time, without cutting any corners, in retrospect, our original projections were based on the collective experience with seasonal flu and with H5N1 vaccine manufacturing, and we're optimistic in the face of what has proved to be a daunting challenge provided by Mother Nature, and despite the best efforts of federal government and our partners in the private sector. Congress and the public have rightfully asked for projections about numbers of doses, and we want to be transparent, but at the same time provide all of the caveats about the uncertain nature of these projections. This has been a real challenge, especially as measures are captured with shorter and shorter sound bites that omit detail about such caveats. And this has led to frustration for everyone involved, especially the public. As an important part of this transparency and part of our public-private partnership, we will start releasing this week, together with all 5 vaccine manufacturers, the number of projected doses by manufacturer for successive 2-week periods. In this past week, storm-related delays nearly derailed shipment of vaccine to many states, from Maine to Alabama. And I want to credit the hard work of CDC and ASPR staff who worked all weekend to be sure the vaccine could be ordered and shipped so the clinics could go on as planned. But we are far from done with the science of advanced development related to vaccines and with building manufacturing capacity in the United States. We're excited that the first cell-based facility will open or have its ribbon cutting next week in North Carolina. But my fear, frankly, is when this is over, we'll decide we don't need to worry about a pandemic for the next 30 years. Nothing could be more dangerous. Despite these challenges, I think that much of what we've learned, and frankly continue to learn through this pandemic, and in the investments we've made to address it, will serve us well in confronting future public health emergencies, as well as for day-to-day public health for years to come. I, too, look forward to your questions.
Thank you, Dr. Laurie. Dr. Goodman?
Chairman Stupak, Chairman Pallone, and members of the subcommittee, I really appreciate the opportunity to be here today to describe FDA's activities in this response. First, when this influenza virus emerged in the spring, we said this can't be business as usual, and we immediately stood up an incident command system response with several teams, for example, in antivirals and vaccines, and this enabled us to mount a very flexible and rapid response with our partners inside and outside of government. In vaccines, our vaccine team acted immediately along with CDC to begin the steps to produce a vaccine even before there was a decision or knowledge that we were going to need one. As you heard, in record time, vaccine was produced and became available. And I can assure you everyone in this effort, government and industry, has done everything possible to get as much vaccine to as many people as quickly as possible without cutting corners. And I know this committee is concerned that a vaccine be safe. A very important perspective here is that the entire world is struggling with the biology of this virus, the challenge of reduced manufacturing yields, and frankly, the entire world is struggling with inadequate vaccine manufacturing infrastructure. Yet despite these challenges we faced in the United States and the frustration we've been talking about, this country is one of the first to mount an effective large-scale immunization campaign. Now, many people have asked us at the FDA, how can we be confident in a vaccine produced so quickly? We have this paradoxical situation where many people really want vaccine and many people don't trust it. Well, I'd like to say that the answer is straightforward and to reassure the American people. The vaccines we've approved are made with methods that are tried and true. Every year, FDA and vaccine manufacturers follow a series of very specific, careful steps to produce new influenza vaccines every single year. And these steps have produced safe vaccines year after year, adding up to hundreds of millions of doses manufactured and used in the United States. And we followed this exact same scientific and regulatory approach for this 2009 H1N1 vaccine. In response to some of the disinformation that was mentioned, I think, by Congresswoman Castor, one of the things we've done, for example, is my commissioner, Dr. Hamburg, with our working together, sent a letter to every physician in the United States to explain about the vaccine, how it was produced, and to provide a balanced review of the benefits and risks of the vaccine. But clearly, we have a lot more work to do there. You heard from the others that your investments in pandemic preparedness have been critically important. With respect to domestic capacity, I want to say that in May, FDA, in an accelerated manner, licensed an additional facility at Santa Fe Pasteur in Swiftwater that the company has said has dramatically increased its ability to produce vaccine, and that is helping us now, so that's important. But clearly, we have much, much more to do. I would also say during this response, we've worked with HHS to bring online multiple additional filling lines to help make sure we can get the vaccine that's produced out there as quickly as possible. Now, on September 15th, we licensed 4 vaccines against the influenza virus, a 5th last week. And I also wanted to point out that, again, in a very collaborative effort with the CSL manufacturer who submitted data to us, we were able to extend the approval of CSL's vaccine to include children down to 6 months of age who we're very concerned with. Now, while we expect these vaccines to have the same excellent safety record as seasonal vaccine every year, we're taking nothing for granted. The same intensive oversight of these facilities, the enhanced safety monitoring Dr. Shukit mentioned, and I want to point out that every single lot of vaccine must be evaluated, tested, and then released by both FDA and the manufacturer before it's used in people. Now, because of the limited time, I won't go into the work we've done on antivirals and diagnostics. I do want to say that we've prevented, for example, through emergency use authorizations, discarding of antivirals that we scientifically know is safe to use, and that's helped avoid shortages. Diagnostics have been fielded in record time, within weeks of a new disease, thanks to CDC's effort and our work with them collaborating to evaluate those. You've heard about protecting the public from fraudulent and counterfeit products. We almost immediately put a team in place to surf the internet, to deal with consumer complaints. My favorite is the magic wand that can protect against everything, including anthrax and H1N1. But you also heard there are issues of counterfeit and unapproved medications. We're continuing to be very vigilant in this respect, and we've actually put a widget out there so others can spread the word with the lists of counterfeit products. Now, looking ahead, I really do feel much has been accomplished in a very short time, and it's because of these strong collaborative efforts. The people you're seeing here and many more are talking every single day. We're talking with the states, we're talking with the manufacturers, and this has been going on from day one. But we need to ask ourselves, and we are asking ourselves, what do we need to do more, both right now for this epidemic and moving forward? Clearly, you've heard about we need more capacity, we need cell-based manufacturing, and we at FDA are very committed to make that happen. We recently, last year or the year before, provided guidance so we could get cell-based vaccines, but we also want those to be safe. We're supporting with HHS development of recombinant and newer technologies that could help us respond even faster. And I think, as I heard from one member, this is important not just about flu. This is important about other emerging infectious diseases. If we had SARS, if we had a bioterrorist attack, we need a strong technologically advanced vaccine infrastructure. Now, due to time, I think I'll stop there, but just to say that we at FDA are very committed to working with our partners and you to protect the health of the American people. We've moved forward with a very flexible, rapid response while taking our responsibility about the safety of these products very seriously. We really want to encourage strengthening our infrastructure here. I also want to mention again that this is a global issue, and we in the United States can work with global partners to strengthen the global response. None of us are safe and well protected from infectious diseases until we all are. So I thank you for your support for public health, your support for the FDA, and your interest in this issue. Thank you very much.
Thank you, Dr. Goodman, and thank you to all of you. The way we proceed now is we have a 5-minute period of questions from members going back and forth, Democrat, Republican. For members who passed on their opening, they get 7 minutes. They get to add their opening to the 5. I'm going to start with myself, and I want to start with Dr. Schuchat. The biggest concern that I hear from my constituents is about the distribution. And I know that the CDC has guidelines for distribution, but basically leaves the distribution up to the states as long as they meet those guidelines. My concern is whether that's a good way to go about it. I mean, I suppose, you assume that the states and the locality, since they're closer to people, would have would be the best way to distribute, but that's been seriously questioned in the last few months or so. And of course, being from New Jersey, the biggest issue has been the Wall Street companies, Goldman Sachs, Citigroup. I literally, being from New Jersey, hear about this constantly. Why is it that New York, I guess, gave Goldman Sachs and Wall Street firms the opportunity to do this? I'm told that employer-based distribution is meet your guidelines, and perhaps it was assumed that they would do well since they have health clinics and have a good distribution amongst their employees. But I guess the concern would be, if you leave the distribution to those who do it best, and the ones that do it best happen to be high-powered Wall Street firms, then there are two concerns. One would be, does that make sense, given that maybe a hospital or school might not do as well a job as distributing, but there's a greater need? And then the second thing is whether or not some of these firms would would only give it to high-risk people, and as opposed to maybe their CEOs or somebody else. So, I mean, that's the concern. I mean, my question really would be, why does the CDC leave it up to the states to create the plan for distribution? And wouldn't it perhaps be better to have, some other federal mechanism rather than doing it this way? And what prevents somebody like Goldman Sachs, getting it when it maybe should be going to a clinic and monitoring how they go about it?
Thank you. The CDC issues national standards about the populations at greatest risk for disease that are recommended to receive vaccine when there's a scarce situation. So we issue that as a national level setting. We leave it to the states or the large cities like New York City to find the best ways to put vaccine in the path of the priority populations, to identify the venues. New York City actually put hospitals and doctors' offices first. They put employer clinics in a lower tier, and small numbers of doses went to some employer clinics.
But the problem that I'm hearing, and I don't have a lot of time, is that in some of those cases, I don't remember which Wall Street firm it was, they actually had excess and didn't need it. So, you could argue that maybe they're getting fewer dosages, but, it may very well be that maybe all or most of what they got should have gone to the hospitals because there's a greater high-risk pool there.
Yeah, I think
and how do we prevent that?
Yeah, I think that that issue was of concern to all of us. Dr. Frieden sent a letter out to all of the health officers and reminding people about our priority groups and how critical it is for all of us to adhere to them. Every provider or venue that gets vaccine signs an agreement that they're going to follow the recommended target populations. So
no, and I understand that. I'm not suggesting,
groups.
Although some have, that Goldman or others are giving it to people other than the high risk, although some are concerned about that. But it's just that, have you thought about the fact that, if you do it that way, or if the states do it that way, it may be giving it to people that have a better distribution network within their employers, but they may not have as great a need. Or, I mean, it's sort of like, when there's a grant program and the guy that does the best, has the best grant application person gets the grant, whereas maybe there's a greater need for the person who doesn't have an expert to do it, Yeah.
We have had a major commitment to vulnerable populations and to the underserved, and to make sure that we're not leaving behind those without good access. Most of the states have carried out these larger mass clinics to get people who do not have doctors' offices to go to.
Well, if you could just, I don't know if you have it, but I would like to see maybe get back to me at some point and to talk about why this kind of distribution is better, as opposed to maybe looking at some kind of a federal alternative. I don't know to the extent that you've looked at that, but if you could get back to us at some point. And then the other thing I wanted to ask Dr. Lurie is that when Secretary Sebelius testified before the committee on September 15th, basically left us with the feeling that we were on track in terms of adequate supplies of vaccine. I know that turned out not to be the case. Some of you have explained why, and I'm sure we'll get more questions from other panel. But you did mention underfunding, and I don't remember her saying anything about lack of funding. You said that there's underfunding, or chronic underfunding was one of the contributing factors. That's the first time I've heard that, and I was a little disturbed because I don't remember her mentioning it.
Let me try to clarify here. I think the chronic underfunding has been in the vaccine infrastructure overall, as opposed to the response. So it would have been wonderful if we had had more manufacturing capacity in the United States by this point, if we'd had, cell-based or recombinant technologies that could surge and really produce large amounts of vaccine. But, while we've invested in that over the past few years, we need to continue to make a much more robust investment. And so that's the kind of chronic underfunding for the vaccine manufacturing capacity. I think we all know that the chronic underfunding in state and local public health has been a different kind of problem. But Congress has been extraordinarily responsive to the very acute needs that we've had to deal with this pandemic. And what I'd love to see us in a situation of is that we can sort of apply prevention in that sense too, and really get ahead of this for the next pandemic or the
Well,
next.
again, I don't want to beat you guys up today, but I mean, when it's something like that Congress can make a difference, it really is important that if the department or anybody feels that there's a need for more funding, to detail that to us. Yeah. And again, I would ask you maybe to get back and give us more information about this chronic underfunding in writing, because a lot of things that come up here we can't do anything about, but that's certainly something that we could.
Well, we look forward to working with you on that.
Thank you. Mr. Walden.
Thank you very much, Mr. Chairman. Dr. Lori, thank you, and thank you all for your testimony. I know Secretary Sebelius did state in retrospect that the vaccine manufacturers had painted a quote-unquote rosy picture. Now, some of you have testified you've been in contact almost on a daily basis with these same manufacturers. My understanding is you produced the seed that they used to produce this vaccine was made available to them on June 23rd. We had testimony September 15th from Secretary Sebelius saying everything seemed to be on track and fine. So to explain did the manufacturers, weren't they straight with you? What's this rosy picture piece?
I think,
is that blaming the manufacturers, or
I don't think there's anybody to blame here. I don't think that there's a smoking gun, and I want to make that really clear. It is a very complicated process. What we've tried to do is put together a little graphic here that shows you all of the different points where things can break down. So I think in the very beginning, when we had that seed strain and started making vaccine, everybody was very optimistic.
Right.
Nobody anticipated how hard it was going to be to get this thing to grow. Manufacturers got a new seed. They started having increases in their yields.
So when did you, I don't mean to cut you off, they only give us 5 minutes here, so to solve the whole vaccination issue. When did you first learn vaccine production was going to be delayed?
Well, so what I should say is that we learned at several points along the way. We learned, over the summer that there were problems with this vaccine growing.
Right.
We learned in the fall that there were problems.
And my understanding on that is that a regular vaccine or the traditional flu vaccine would produce about 3 doses per egg, and this was producing like a tenth of a dose or something?
Somewhere between, 0.2 to 0.5 or something.
Okay.
So that was very challenging. And what I will say is that at every step along the way, when we got information that things were not going as quickly as possible, we actually downgraded our estimates, and we got that information out to the American public.
When did you first get that? I guess what we're trying to get at here is, I was here for that hearing on September 15th, and I walked away thinking, wow, that's a pretty strong statement to say we're going to have vaccine for everybody on schedule, on time, and 20 million doses in October, or whatever the number was. And then we got people waiting in line for hours, and I mean, people are really frustrated. And
I think we're all really frustrated. I don't have any doubt about that. I think.
But did the secretary know when she testified in September of these delays?
When she testified in September, those initial getting the virus to grow problems had been largely cleared out of the way. Then, as happens, other problems happened. Problems in getting production lines up and running, for example, just took longer than they could have. So it actually took longer to get from those big vats of vaccine into vials that you could actually ship out to states, just as another kind of example. And at every step along the way, even now, we still have problems. If a dose gets shipped here and a temperature sensor goes off, or like
I understand that.
Things happen. So at every step of the way, things happened. When the secretary testified, she was using the best available information she had at the time.
Okay, let me move on to a different topic then, because one of my colleagues who had to leave wanted me to ask if we could get for the committee the contracts you entered into with the manufacturers. And if we could, is that something you can provide?
Absolutely.
Okay, and then one of the questions that's come up is, in the contracts, did the manufacturers or did you request knowledge as to whether or not these offshore manufacturers, which is all but one, I understand, that their countries, like we have the authority, can say, produce the drugs for us first, and then you can ship to the U.S. Was that discussed with each of these manufacturers, and did HHS know ahead of time kind of where we might get a manufacturer that is required by their in-country law to provide the vaccine there first, and we might have been relying on that shipment here? Did that pose problems? Did we know?
Sure. Let me say first that these contracts are all structured so that manufacturers don't get paid till they produce vaccine.
Sure.
Okay, and I just want to make that clear because I think that there's been a lot of confusion about that. And we've worked really hard to be responsible stewards of society's resources in that respect.
Right.
Yes, almost every country has what this country.
So you knew going in.
So going in or early on into this, we did know that other countries had this act. I also want to just say that despite the problem in Australia, CSL has worked very, very hard to get us vaccine as soon as stuff got freed up.
The final question, because it's new and wasn't, I believe, in your testimony, is your reference to this vaccination team that's been sent to Delaware.
Mm-hmm.
What is that about, and why Delaware, other than maybe the vice president?
Because they requested it. But so one of the things that we did in working with our colleagues at CDC and state and local health departments is we said we want to do everything we can to help everybody be successful and get vaccinators out there. So if within your state you don't think you can mobilize the resources to get populations vaccinated, we actually, through the National Disaster Medical System, have trained about 15 teams now that on request could go out and help get
so
those
one's out and the other
vaccines
14
into arms and noses. There is one out there, I think next week, to help on college kids.
And are other states requesting that, and how do they do that?
Go ahead, Andrew.
Just to add that CDC has also received requests, and we have adapted. So this is Dr. Lori's describing one mechanism. CDC's got other mechanisms, but everybody's shared goal is to support the states in succeeding.
That's terrific. So those vaccination teams are available through HHS, limited numbers, and states can apply, and you're communicating, I assume, with our governors on how to do that.
Yes, we are.
All right. Thank you very much. Thanks for your indulgence, Mr.
Sure. Chairman Stupak.
Thank you, Mr. Pallone. Let me ask a couple questions because I'm a little confused on a couple of things. What I've heard everyone say is that, or Dr. Schuett, you said next time we will have more time, we will have more vaccines. We've learned, Dr. Lori, you said that we've gathered data from around the world, and the H1N1 has not mutated significantly since the spring, and we're doing what other countries do. And Dr. Goodman, you said that the entire world is struggling with the biology of this virus, and that you worked with foreign governments and the World Health Organization. Can you show Exhibit 4 for me? When I was looking at this, HHS has put out a timeline, the 2009 H1N1 activity timeline. And I noticed the antivirals was very important page I looked at. And on the antivirals there, I saw here on April 28th, HHS released this 11 million treatment courses, 25% of federal antiviral stockpile held in the Strategic National Stockpile to states in anticipation of state influenza efforts. The Secretary approves the procurement of 13 million treatment courses to replenish those to the state and Mexico. And we know it started in Mexico, at least on this side of North America, and this was in the spring. Mexico was having trouble. We sent them 13 million treatments. April 30th, HHS provides 400 treatment courses, 1% of the nation's stockpile, to Mexico to help spread the virus. And I have no problem with doing that. But what did we learn from all these countries? Because it seems like the problems, and we had supply help out Mexico, that number one, there was a shortfall. Number two, we're trying to come up with vaccine formulary. Number three, does only one dose work, or do we need 2 doses? And 4, what about the young people, especially the pediatric deaths that we're seeing in this country? Didn't we see that, all those same things in Mexico? So, go ahead.
I can probably begin and let others finish. We've worked very closely with the global community to learn as much as possible about the behavior of the virus in people everywhere, particularly with
okay, but how about these questions?
Mexico?
Did we realize there'd be a shortfall from looking at what Mexico? Did we find a vaccine formulary? Did we realize only 1 dose would work and the young people being injured? Didn't we learn that from Mexico and working with other countries?
1 dose one dose seems to work in children 10 and adults.
My question is, did we
Antiviral-
learn this in April from working with
no,
other
there was
countries?
no vaccine in April. So
Okay.
none of the vaccine
Why'd you ship it to
questions-
Mexico then if there's no vaccine?
No, we shipped antiviral medicines to help them with
to help them do it.
Exactly, because they had people dying in
So did we learn? Yeah, there have people dying in Mexico. So
Right.
what did we learn from that?
Yes, we learned that the clinical severity in Mexico was very similar to here. Their initial reports of very severe disease were because they hadn't actually looked broader in the community. They found a lot more mild disease once they started looking. So we learned that the clinical picture in Mexico turned out to be just the same as what we've had, same in Australia, same really around the world.
So then it still took us 6 months after shipping to Mexico and everything else to learn, number one, we're going to have a shortfall. Number two, that we didn't release the license to these manufacturers until September 15th. We didn't realize we only needed one dose, according to your timeline, until September 11th, and that young people were going to die.
Right. The vaccine clinical trials were carried out during the summer, and so decisions on licensure were based on product submissions to the FDA.
Then let me go to this
were based on
question
trials.
then.
I'm sorry?
Let me go to this question. If we're having all these problems, we know there's these shortfalls, all this is going on, and you have your emergency use authorization, then this adjuvant, are we the only country that doesn't require an adjuvant, that we said no adjuvant? If we're learning from all the rest of the countries, other countries aren't using adjuvant, why are we insisting on we're non-use, right?
We're not using adjuvant.
Yeah.
We
Every
actually
other
have more
country's
vaccine
using
than
adjuvant,
the other
right?
countries do right now.
Yeah, other countries using adjuvant, right?
Some are using adjuvant.
Okay, why aren't we? Especially when our suppliers are telling us we can quadruple the amount of vaccines available if we would have used it, when we realize we have all these short supplies, and you have an emergency authorization, emergency use authorization, and the President issued a national disaster declaration on October 24th. So you're looking at the rest of the world. Novartis and some of the other manufacturers tell us, look, we can quadruple your supply just by using the adjuvant, and we say, no, we're not going to do it.
Well, let me see if I can begin, and maybe Dr. Goodman would also like to comment. Adjuvants haven't been licensed in the United States. We haven't had a lot of experience with them. And
Correct.
so
The rest of the world has.
Their safety profile was not known. And so we got all of our top scientists together, and we made a decision that if the situation got a lot worse, then we would use adjuvants. But if
How much worse does it have to be before we
Well,
use adjuvants?
If not, that we thought, since the unadjuvanted vaccine also worked quite well, that was a better alternative for this.
But we receive 25% less than what we could have if we would use the adjuvant. What is the problem with the adjuvant, other than we haven't done the test here in this country?
Well, as you know, the public's confidence in our vaccine system and in vaccines in this country is very, very fragile.
Sure.
We made a commitment not to cut corners and to use vaccine that had been demonstrated
But
to
it
be
seems
safe
like
and effective.
we rely upon data from rest of the world when it's in our convenience, but then yet when we look at the track record rest of the world and this adjuvant, whether or not we add or not, suddenly we decide to go different. The M59 adjuvant that Novartis talks about says, look at rest of the world, they had to change because the United States told them to change the formulary. So were we taking into concerns and needs of other people or just our own people based upon our own interests? And we could have had more supply out there if we would have looked at what Novartis and these others are saying works.
You know, one thing you may not be aware of is that the demand for the vaccine is actually much higher here than it is in Europe, and there's quite a bit of skepticism in Europe.
I agree.
So I think we have a very complex environment.
We've hit it a little quicker than Europe. Europe may hit it here pretty quick, right?
Absolutely. But I think the other point is, as Dr. Lurie says, at several steps since last spring, the government has reevaluated the adjuvant decision. We've looked to our external advisory groups. We've considered, is this a scenario where it makes sense? And we don't feel that we've reached that point given where we are with production.
Chairman Stupak, maybe I can add one thing that may be helpful to you. One is that we are working very hard with the manufacturers, and in fact, we've asked NIH and the manufacturers to study these adjuvants, including with H1N1, to give us more data. The other point I wanted to make is that the vaccine you mentioned that is marketed in Europe, so there is one previously approved adjuvanted flu vaccine in Europe. However, that was only previously approved for the elderly. So in terms of the kind of broad experience with millions of people, That's only in the elderly, who were not a focused population for this vaccine. Finally, I do want to point out that it's not those identical vaccines that would be available here for our citizens, but vaccines where the vaccine material itself is manufactured in other facilities and then combined with those adjuvants, and there's much less information about that combination. And again, that's why it's important for NIH and the manufacturers, who've been very cooperative, to provide this information. So we don't have enough data about those at this point or at the beginning of the pandemic for them to meet the standard of FDA licensure. However, we have said all along, and the senior scientists at every agency at a scientific level are meeting periodically and reassessing this decision. In fact, a decision was made to go ahead and stockpile adjuvants and have them ready if they're needed. The good news has been that
what's the point
normal
when they're going to be
doses of non-adjuvanted vaccine have induced an excellent response, just like every year.
But if you're stockpiling to determine if they're going to be needed, what is the breaking point when you're going to determine if they're needed, if you already stockpiled it and it can give us 4 times more of the vaccine?
I think initially, for example, exactly what you're asking, a breaking point would have been if a normal dose didn't give a good response. Another breaking point would be if the virus changed dramatically and it looked like an adjuvanted vaccine could provide better protection. But I think we're very open to this, and we've really tried to walk a line based on the science. And it's very complex science, and we look forward to getting more information, and we're committed to continue assessing it going forward.
Let me just
Mr.
add that we
Chairman, you've been
revisited
generous.
this decision.
1 minute. He's been generous with his time. I'm way over. I don't mean to. And the next panel's coming up because I'm going to ask him the same questions. I still think we could have quadrupled our supply and taken care of our short supply if we weren't so short-sighted in this.
Thank you. We have 8 minutes left. We have 3 votes. Mr. Shimkus says that he'd like to go next before we break, and then after him we'll break and come back.
Thank you, Mr. Chairman. And I'm just going to be pretty short. But I appreciate Bart's focus because, as in my opening statement, I hope that we do an after-action review on this process to help us be prepared, because the questions that he's raising is really the questions that I would have under a terrorist attack, biological element, and weapons of mass destruction. And it really keys into what Bart has said. We have to have a way to streamline the process and get approvals quickly, and that would be the debate on egg versus cell and how quickly. I understand the FDA's responsibility, but if you have a massive possible pandemic, we better have a way to subvert the regular order for the needs of the whole and move rapidly, just like Bart's comments on the adjuvant. And I hope there is a process in place, and if there's not one, I'm former military, and after every training exercise, you do an after-action review. And will that be done, Dr. Shukat?
Yeah, what I can say is we've actually had several in-process reviews already, and we are committed to after-action reviews as part of our routine procedures.
Dr. Lurie, anyone else want to?
I would add to that, and I would also add that there are processes in place now through emergency use authorizations, so that if this pandemic were to become much more severe, et cetera, we would be able to shift to other products under an emergency use authorization. And that's been part of our pandemic planning since 2005.
And because if something hits that we don't even know about and we're looking at this timeline, then I guess we just identify it and then isolate people until we can roll out, some.
Absolutely. There are several mitigation steps, and one of the things we did this summer is update guidance for mitigation, what to do with the current level of severity and what we might do if the virus mutated and was much more severe. So no automatic school closures in this setting, but if things change substantially, we would go to much more disruptive interventions. And so we do have things that were available to us, knowing that vaccine supply might not come soon enough.
Yeah, Dr. Goodman.
Yeah, I really appreciate your comments, and we want to have a very agile public health response, especially in an emergency. I do want to mention that in that respect, it took us about a day or two when there was a need for antiviral, not approved for children under 1 year old, but to treat children under 1 year old, to work with our colleagues at NIH and CDC and issue an emergency use authorization. Full transparency to the public, not the kind of data required for approval, but appropriate risk-benefit weighing in a public health response. This is a tool you in Congress have given us, and we're ready to use it when there's the right emergency. And as recently in the last couple of weeks with respect to the adjuvant question, the senior scientists of every agency have sat together and revisited that decision and decided, do we want at this point to switch to adjuvants? It's a very complex discussion, but that is being revisited in action, and we're committed to continuing to visit it after action. The biggest improvements we can make are strengthening this infrastructure and getting new technologies ready ahead of time. We're better prepared than we were a few years ago thanks to your investment, but we have a long way to go.
And I'll just end by saying I think education is the key, and what's the positive aspect is the public is really better stewards of everybody else's public health by better health practices, and that will be the key thing before we can roll into this. Thank you, Mr. Chairman, for letting me get this in.
Thank you. So we have 3 votes, and we'll come right back after that. The subcommittee is in recess.
basically, what that tells us is that if we need, material for the safety and security of this country, that we can prioritize that. And I think many countries have that kind of situation that they need to prioritize for their home country. That's why it's so important for us to get to domestic manufacturing capacity in the United States. It's actually something that we learned and realized during our pandemic planning early on. And in fact, even earlier than that, when we realized several years ago that we were down just to one licensed flu manufacturer in the United States. And I think people have worked very hard to get to the point that we are today. And now we need to get to the point where we have much more domestic manufacturing capacity. I think in the case of CSL, they're based in Australia, and they have a similar kind of arrangement and requirement with the Australian government. Remember that the Southern Hemisphere has its outbreak at a different time, and so Australia was experiencing a pretty severe outbreak, and decided that it needed vaccine first for its home country. Now, when that happened, CSL let us know that right away. We immediately were able to downgrade our projected numbers of doses of vaccines. And at the same time, we worked very closely with the manufacturer so that as soon as they met the requirement for their home country, they were able to start making and shipping doses to us. In addition, I think as you heard, they've also submitted additional data recently so that their vaccine can be used down to lower age in children, and that was really recently licensed.
I also, in my opening statement, talked a little bit about using this pandemic, this seasonal flu as well as the H1N1, to learn and to innovate. And I'm wondering what your thoughts are in three particular areas. One is faster manufacturing processes, whether it's cell-based or things that other opportunities there, use of adjuvants, and alternative methods of vaccine delivery, something other than injection and nasal spray. If we were to have a very virulent influenza next year, where would we be in a year that we aren't today? What's your sort of time horizon for when these innovations are going to be more generally available?
I think it's a really great question. I think, again, BARDA is in right now year 3 of a 5-year strategic plan to really try to move us toward more modern manufacturing technologies and manufacturing capacity in the United States. As I said, the first cell-based facility has its ribbon cutting next week in North Carolina, but it actually, I don't think, is going to be able to make flu vaccine for another year. But when all said and done, that ought to get us to the point where they'll be able to make, I think, 150 million doses. So that's still far short of the capacity that the surge capacity we would need in a public health emergency. In addition, cell-based vaccines still require the virus to grow in cells. And so we need to move toward, recombinant technologies and other kinds of technologies. We have invested in some of those. I think there's a lot of promise in a number of the new methodologies. I can't yet predict where they're going to come online, but I also want to say that it's great to be able to do those things, but once you do them, we can't forget that we have to manufacture to scale with whatever those are, and so we have to be thinking now about, how those new technologies and manufacturing capacity meet one another, so not everything is done, one after another. And so that's, I think, another real challenge that we have. With regard to adjuvants, I think, we all know and believe that adjuvants have a lot of promise. And just to reiterate, adjuvants really are used for two reasons. One is so you need less vaccine. The other is if you don't get a good immune response to that vaccine, they help you get a better immune response. It's a substance that you mix with the vaccine. There's a lot of work going on right as we speak to understand the experience with adjuvants, trials being done by the manufacturers, as well as by NIH mixing one company's adjuvant with another country's vaccine to be sure that those things are safe and effective. And depending on the outcome of those trials, you know, I would expect that if they're promising that the manufacturers will submit applications to the FDA, but that we're not there yet. And then in terms of the alternative methods, people are working on things like patches, you know, a transdermal method. Some people are working on vaccines that you can eat. You know, there's a lot of very exciting breakthroughs in the science that I think are going to move us far forward. Some are more ready than others, but it would be great if you could use a patch instead of a shot, for example.
It's my understanding that some of that technology also may have an impact on increasing the effectiveness of the vaccine. You know, for example, skin, you know, microneedle application versus injection.
Right, and I think we're continuing to learn more about those, but I think a lot of these new technologies are very promising in terms of also being able to get a better immune response. It's really the immune response, and it's sort of how it gets into the body to make that immune response that is the difference in some of these different technologies. I don't know, Dr. Goodman might want to amplify on that.
You know, I would just add one thing, which is there is a lot of amazing innovation, incredibly promising technologies. We have licensed cell-based vaccines in this country, just not for influenza. That's been a real challenge. We have licensed recombinant vaccines in this country, just not yet for influenza. And I think those things are making some really real technological progress, and those are things that we're going to see progress in very soon. But, you know, one thing I wanted to say is we see, even in the most sophisticated manufacturing technologies, there are still challenges producing large amounts of things consistently and of high quality. So even with some of the most advanced biotechnology products out there today, this is complex, challenging manufacturing. And it's not like just, I mean, the egg has been amazingly efficient and for all some of the problems, relatively reliable. Clearly, it's an old technology. It has many disadvantages. But I'm just pointing out that some of the newer technologies are going to need the same kind of care, and that what works in a mouse or what works in a very small production is not always the same, that and it sometimes takes some time to get it to industrial scale and be sure it's going to be safe and high quality for people. But we're all working together to accelerate that, because our goal should be for an emerging infectious disease threat to have vaccines, you know, much, much faster, you know, much, much faster. And there's promising technology that can help us do that.
Thank you. I want to thank all of you for your comments today. And I know that we did have some questions that I and others asked if you could get back to us in writing. The process is that members can submit additional questions in writing to you, and usually they're supposed to be submitted within the next 10 days. So you may get some additional written questions to respond to as well. But thank you very much, really, for such an important issue and that you're so involved in it. You had some comments?
Well, I just wondered if it might be okay if I just responded to something I heard in a couple of comments earlier, because I was just very concerned, and we haven't really had a chance to, I think, correct some misunderstandings here. And that has to do with vaccines going to Guantanamo or vaccines going to terrorists. There's no vaccine on its way to Guantanamo. There's no plan to vaccinate terrorists or Khalid Sheikh Mohammed ahead of anybody else right now. There's a program that's handled by DOD, but I think it's one of those things that gets out there in a soundbite and it sort of travels virally, and there's a lot of misinformation out there. There's no vaccine on its way there.
All right. Thank you very much. And did you want to, I'm sorry, Mr. Gingry's here. He hasn't had a chance to ask a question, so go ahead. The gentleman from Georgia is recognized.
Mr. Chairman, thank you. I'm pleased that the first panel is still here. You know, I have some concerns, and I, in the interest of full disclosure, I've been a bit of a doubting Thomas as a physician member about our response to this crisis, this pandemic as it is now. And of course, my great concern was us creating a pandemic of fear. I think we have certainly done that, and we also have since 2006 when we were dealing with avian flu, probably in the aggregate have appropriated something like $12–13 billion. Feel free to correct me if I'm wrong on my numbers, but a lot of money. And, of course, as we track this, and the concern was whether or not to develop and spend billions of dollars in the process and develop a vaccine specific to H1N1, different, of course, from the regular vaccine that we will be producing for seasonal flu. I think the decision was going to be made, I guess was made, on the basis of how virulent this strain became and what kind of changes might occur. Was it getting worse? And I think that you've said in your testimony, maybe all three of you, that the strain really hasn't gotten worse, and the virulence has not increased. But one thing that I did notice here lately was that from all of a sudden we went from 1,000 deaths in the United States literally overnight to 4,000. And that's I find a little disingenuous. But there's been this explanation that, oh, well, we originally were basing cases of H1N1 on laboratory evidence. But now we are using a mathematical formula that we kind of extrapolate or estimate. Some people maybe in the CDC ought to go to work for the Census Bureau with those kind of calculations. And I mean, I have real concerns about that. And in fact, I brought along with me a blank death certificate where it says cause of death and contributing factors and that sort of thing. And I would be really curious to know how many of those 4,000 cases does the death certificate say the cause of death is H1N1 viral influenza?
Thanks for those comments. Communication is really important to all of us, and being clear and not confusing. We did not overnight go from 1,000 deaths to 4,000 deaths. All along, we've been talking about using a variety of surveillance systems appropriate to the period of the pandemic and the efficiency of data collection. And we've said that reported cases underestimate the true burden of disease. With seasonal influenza, when we talk about how many deaths or how many hospitalizations they are, that's not based on individual reporting by doctors and health departments or so forth. It's based on looking at a lot of different data sources and modeling those data. What we did last week was release estimates that took information from a couple very good surveillance systems. Hospitalization data from our Emerging Infections Program network in 10 different states, information from 30 or 35 states, depending on the week, about laboratory-confirmed hospitalizations and laboratory-confirmed deaths. We use those two as a ratio to understand from hospitalizations how many deaths might there be. We looked at the influenza-like illness surveillance system, our Sentinel providers, to divide up states into high, medium, and low at any one time in terms of how common the transmission was. And then we used correction factors that were based on community surveys done to really understand for how many illnesses are in the community, based on household telephone surveys, for everyone who actually goes and sees a doctor. How many people that see a doctor get a lab test? And
Dr. Shuckett, with all due respect, because my time is limited, I want to make one other point, and I appreciate your explanation, and I hope all of the panelists, all three doctors, understand my concern. The State University of West Georgia is in my district in Carrollton, Georgia, and they weren't having a problem getting access to the vaccine. I know that's been the main theme of this hearing, why we didn't develop millions, literally 50 million vaccines by a date certain October, and it was only 15 million or whatever. But State University of West Georgia had no problem. They had plenty of vaccines. They have 11,500 students, and only 141 were willing to be vaccinated. And a lot of them are very concerned. And let me just give you a quick quote. Most students are saying that they haven't gotten the swine flu yet, so they believe that they are not going to get it at all, said Chandra Jones, a student who is from Franklin, Georgia. There are also people telling students not to get the shot. There are some who are afraid of the side effects of the shot, and they've read about 1976 and Guillain-Barré syndrome. They believe that the government did not test the shot enough, end quote. Mr. Chairman, I know I've extended beyond my time. If the panel, if you would allow them as a courtesy to respond to this, because I think this is a huge issue. I don't care if if we've got 100 million vaccines and 10% of the population is willing to take the vaccine, even those that are high risk. What have we really accomplished here?
I'm going to let you answer Mr. Gingry's question, and also, but I got to be careful here, Dr. Lurie, because you opened it up to the Guantanamo thing. Chairman Stupak wants to say something too, so we'll do those two, and then we'll be done. Oh, no, we're not done. Mr. Green is here. I give up. All right, Mr. Gingry. Respond to Mr. Gingry.
Sure. You raise one of the most challenging aspects of this pandemic. At the very same time, people are waiting in line, driving hours to find vaccine. We have supply way in excess of demand in some communities. We have huge information needs to fill, and I think we are really committed to break the myths about the safety of this vaccine, what we do know and what we don't know. There's a website, flu.gov, that has a lot of information about myths and facts that might help some of the college students understand what is the case. We've actually planned for some more outreach for youth such as college students to try to reach them and have them understand what is the threat to them, what are the risks or not about the vaccine. But we have this very exquisitely challenging time where do we risk raising demand in some communities like that at the same time we have so much extra demand versus our supply elsewhere. And that's one of the reasons why we've really focused on state and local support, because in your community, your public health experts understand on the ground, we got a supply-demand mismatch the other way at West Georgia College, whereas in the national level, we may not really understand the community's supply and demand. And so really one of our reasons to focus on state and local distribution or direction of where the vaccine goes is because of that trust of the community and that awareness of what's going on with the local community. So I think that if you want to get back to Gitmo, right, okay.
Are you done with Mr. Gingry's response? Okay. Mr. Green, let me just explain what happened is it looked like we were done and there was nobody here. So Dr. Lurie asked to take some time to talk about terrorists in Guantanamo, and Mr. Stupak just wanted to clarify and ask a question about that, and then we'll go to you.
Dr. Lurie,
Yeah.
You don't have anything to do with the military and getting the control of the drug to the military, do you?
No, this whole program is run by the Department of Defense.
Right.
Right. And
so you don't know if people at Guantanamo's received it, if anyone at Guantanamo's got it. You don't know if the 218 international terrorists we hold in U.S. jails has received it. You don't know that because that's handled by a different part.
What I can tell you is, like all military installations,
what is your source then? If
run by the Department of Defense, and they have pretty strict criteria, just like we
Correct.
do how
they
do prioritize vaccine, going to U.S. forces,
correct,
deployed healthcare workers, civilians and contractors,
correct. But the point is,
civilians, et cetera. So I heard.
But the point is, under oath, you said they did not receive it. You don't know that. When Major Diana R. Haney says they'll be receiving it on November 2nd, they could already have the vaccines down in Guantanamo on. This was November 2nd. It's now what, the 18th? 16 days ago. They could have it there. You really don't have any personal knowledge of it.
No, I'm sorry. What I was trying to do was correct a misconception about how the vaccine was distributed. I do not have personal knowledge of that.
Correct. I realize uniformed personnel first and are required to do it. And even these detainees will have a right to accept it or refuse it. But the point being, this was released November 2nd at the time of the height of the shortages, and American people were upset about it. I have no problem, but I just say, you're under oath. Don't be testifying things you don't have any personal knowledge of.
Fair enough.
All right. Mr. Green.
Thank you, Mr. Chairman, and I appreciate the patience of our witnesses. You've been here a long time, plus you had to listen to our opening statements. But that's just the way it works here sometimes. I appreciate you being here, and I guess the frustration is because we've had both the Health Subcommittee, and I'm both on the Health Subcommittee and the Oversight, and we've had a number of hearings since the spring, and the most recent one in September. And it seemed like the best plans that we had just didn't pan out. And it's not necessarily with the delivery system. We'll hear from that at the next panel. We have the Commissioner, and but we'll also have on the manufacturing side the next panel. But, you know, there's been talk for many years about what we need to do for pandemics. And yet here we have what relatively is can be major. A month ago, we had a Homeland Security hearing in Houston, Texas, and we had 1,000 people died. Now it's up to 4,000. If it had been something much worse than H1N1, we would be sitting here and saying, why are we having tens of thousands of people dying for avian flu? What do we need to do, or the agencies, all your agencies and even Congress need to do to live up to the plans and the expectations that we had from the earlier hearings, where we were going to have enough vaccine. The distribution system was there. Right now, we don't know if the distribution center is there simply because we don't have enough vaccines, although we know something's working because people are lining up all over the country to receive it. And the other question I have is that my concern is that the lack of regular flu vaccine, or at least the participation. And the one thing we know now is hopefully next year, or the next flu season, we will have H1N1 in with the seasonal flu, but that we need to make a national effort to increase the seasonal flu vaccinations, and that comes from all of us. We have seen a little uptick because of the fear of H1N1, but I want to see what we can do to the cheapest thing we can do for the business community is a flu shot for their employees. So with that, in the time I have, 2.5 minutes for all three of you from your agency.
Yeah, I think there's several things we could do to strengthen our response for seasonal flu as well as for a future pandemic, which I do believe we will have. We have a public health infrastructure that's weak right now. It has been suffered many job losses, many furloughs, and it leaves us a little bit of a weakened core to respond to this kind of thing. We do not sufficiently use information technology that could help connect the electronic health records in the private healthcare system with public health needs. We could do much better targeting of priority groups if we had better information systems. Some states have immunization registries that work pretty well, but they don't often reach to adults. We don't have a strong adult immunization program in the U.S. Adult providers haven't yet really stepped up the way pediatricians have to use prevention as at the forefront.
And I appreciate that, and we're going to run out of time. But we're talking about pediatricians, and we have a really robust vaccination system for children. We know H1N1 targets children and young adults. I had my 62nd birthday 3 weeks ago, and the first time I said, I'm glad I'm 62 because H1N1 doesn't hit us that much.
But even with children,
we have that
actually,
system now. The problem is we don't have the vaccination.
Right. I think there's two things, though. With we certainly need a more robust vaccine production with a new technology, broader information, broader manufacturing capacity. But with children, if you look at this pandemic, it's really disproportionately affecting school-age children, and they don't go to the pediatricians very often, and they don't get vaccinated very often compared to younger children, 1-year-olds and 2-year-olds. And so there's a tremendous opportunity to strengthen immunization for school-age children. Many states are having great experiences with school-located vaccination for H1N1. Those could be models for seasonal flu, for instance, in the future. But there's a lot of work to do before we would realize the very efficient delivery system that we'd like to have. I don't know if you want to add.
Certainly, I would really second Dr. Shuka's comments about really strengthening the public health infrastructure at all levels. In addition, as we've talked about some already this morning, we do need to get to much more robust manufacturing technologies. We talked about the fact that there are some promising new developments, and we need to continue to invest in pulling those kinds of technologies along so that they can make vaccine faster and more reliably, and then those new developments have to somehow meet the large-scale safe manufacturing capacity so that were we to have another emerging infectious disease, another kind of pandemic, that we would be able to get vaccine out in very large quantities much faster and not be reliant on the vagaries that we have now.
Mr. Chairman, I know I've run out of time, but those of us who are from the sugar cube generation that dealt with polio, I know we use that example many times at our hearings. I think our agencies need to look at that and say, how do we deal with this? Because next time, it won't just make us sick for a few days. It may be killing a lot more people than it is 4,000, because we lose 36,000 people every year from regular seasonal flu. But I'm worried about the pandemic on something much more serious. Thank you, Mr. Chairman.
Thank you. I guess I'm going to say thank you again. I won't repeat what I said again, though, but thank you so much. And again, get back to us with any written comments. We would appreciate it. And now we'll call the second panel.
Thank you.